Yeah, because today is a very small number.
Okay.
Yeah, introduced by themselves.
Okay.
Yeah, okay. So, じゃあ、始めます。どう田辺君。OK? うん。そう。Thank you very much. Okay? So, good afternoon, so everybody. Thank you very much for joining today. So, our seminar. And I want to introduce very simply by yourself to the working section and so what about exciting today for something asking to him. So because today kind of like a general surgery things and also the what is a VCA company because VCA company is the most biggest veterinary hospital company in the world. Yeah. And also he's a general surgeon from the VCA and more than 25 years working Kaneohe animal VCA hospital. So now there are 6 clinics in Hawaii. Hospital actually, not clinics, hospital. But in these 5 years there's so much expanded. So and also Dr. SEVERSON is all more than 20 years working and so watch to the our veterinary market position on the general surgeon doctor, and also I watched them very interesting to growing the company so long time. So today is finally I very appreciated to invite you Dr. SEVERSON to our place. Thank you very much, Doctor.
Thank you.
Yeah, and please.
Okay, thank you. Thank you all for coming. I would like to start by thanking Dr. Katsumi Hama for having me out here. I've never been to Japan. This has been a wonderful trip so far. We were able to bring my wife and my son, and they are busy today too. Also, I'd like to thank Kyoko and also Dr. Komori have been very helpful in helping me prepare the talk and getting our travel arrangements made and everything like that. So thank you very much.
Thank you.
What I would like to do today, or what I hope to do today, and I'm going to try to do it fairly quickly because we have a lot of information but not a whole bunch of time. Go through as much as I can as quickly as possible. Kind of give you some of the things that I've realized through my years of work. I would imagine from talking to Dr. Honma that your level of veterinary care here in Japan is very good. So I'm hoping maybe I can give you a few things that you can take away, but I think that you probably know all
on
this.
time by time.
Yeah.
And every pages I make a time for the question and something opinions. Okay. So and by the way, Doctor, please introduce to the everybody. Okay. So お名前とお願いします。
Maki?
Yeah.
I see.
I'm from
Anicom.
Yeah, Anicom Insurance School for Insurance for Pets. Yeah, I'm very much to your presentation.
Nice to meet you. Thank you.
じゃあ先生もすいませんが、everybody knows about
My name is Dr. Kailua Yes. I've been working with the family of Katsumi for more than 10 years.
Yes.
Previously, I've been working at the Ministry of Agriculture for more than 40 years.
Whoa!
I'm almost retired.
You don't look that old.
Thank you. Thank you.
Actually, my foreign business, the Asian countries business, the pet clinic is also a big supporting all the time.
Hello, my name is Yuko Shiba. I'm working at Sakado Hospital.
どれぐらい僕のとこでしたっけ？もう卒業以来だよね。シンスグラディエーティスでしょ？ね。
I'm working this company up to じゃない何年だっけ
？More than 11 years.
11 years.
From fresh graduated.
Sure, good.
Very important to my human resources.
Yeah.
Because my doctor is like 80% from the own clinic to move to my private business, and also working for a long time for the own clinic, right?
Yeah.
So move to a working side, right? So, but she's very important for the pure my company DNA. じゃあ、有馬さん。
My name is Haruko Minakata, and same place, working now.
Yeah.
And my work is maternity maid in Saitama area.
Saitama province.
Okay.
Is one of the major close to the Tokyo area cover.
Okay. Well, thank you for coming.
Thank you.
Thank you.
で、清子さん。
Yes, that's me.
Yes, sure.
My name is Kyoko Tajima, and I'm working at Dr. Hopper's place as a dog trainer. So this lecture is a bit difficult for me, but sometimes, my client asks me some kind of disease. So this is a great opportunity to have a seat here, and maybe I would like to bring some answer to my client.
Okay.
Thank you very much.
Thank you.
Actually, her section, more than 20 years communication with the Hawaii Dog Trainers Club.
Oh, yeah.
Because my clinic started like 25 years ago. It was the first our trial to the dog, like a family training style. Because before the Japanese dog training is more than the police dog, like a guard dog style, right? So yeah, there are more than 20 years she's working. Thank you very much.
Thank you. Thank you again. Just a couple of slides. I was going to say that in Hawaii, and I don't know if any of you have been to Hawaii yet. I hope that you all can make it to Hawaii at some point in time. I know that the Japanese people have a great love for Hawaii, its culture, our food, and our scenery. This is my son enjoying the ocean. We like to eat well. This is my dog enjoying her bananas.
Oh,
And we also...
Bisla.
No, black lab.
Oh, black lab. Okay, yes.
Her name is Kaimana.
Yeah.
And we also enjoy our drink too. She's a crazy little girl. So a little bit about myself. I grew up in Hawaii, went to school initially in Illinois, a small university there. I got my DVM degree from Fort Collins in Colorado State University. I then went to Connecticut, spent 1 year as an intern at a private hospital, spent 1 more year after that, and then went to Cornell University where I completed a residency in small animal surgery. Moved back to Hawaii with my wife in 1991 and started at the Companion Animal Hospital where I first met Kyoko's friend Lorella Peng. And then in 1997 I joined the staff at VCA Kaneohe Animal Hospital. My duties there, I'm a general practitioner. I also do a lot of the surgeries for the hospital, and I do take referrals from neighboring practitioners too. We do host veterinary students for externships, anywhere from 2 to 4 weeks, and I also do host high school students who want some mentoring into veterinary medicine. Quickly about VCA itself, we are, like Dr. Honma said, the largest veterinary organization in the world. Presently, over 600 hospitals spread throughout the United States and a handful in Canada. Most of these practices are small 1, 2, or 3 doctor practices. But as VCA has grown, they have also developed numerous very large referral centers. We do have one in Hawaii now, it's VCA Family. At the referral centers, of course, they have many specialties. They take referrals from the neighboring hospitals. They will also, depending on the location, have 1-year internship programs for recent graduates, and they also do support residency programs in various specialties, both at the referral centers and also sponsoring a residency program at the veterinary teaching hospitals through a university. So VCA is very much in tune or aligned with improving the quality of veterinary medicine throughout. Some of the newer things that we're doing at the VCA is wellness plans. Big push to help or to emphasize the preventative care for our animals. Care Club is a new thing that we've started this past year, and what that involves is if a client chooses to participate in this program, what they receive is 5 office visits a year, all the vaccinations, yearly blood tests, and heartworm prevention, stool checks, and they can also purchase a plan that would include a dental cleaning every year. The nice thing for the client in this case is that the cost of that has a little bit of a discount, but it's also spread throughout the year. So the client can pay a smaller amount monthly to enjoy the benefits of it without having to be hit by one big bill in 1 year. So it allows them to budget for their animal's care. VCA is also owner of Sound Imaging, which is a digital radiology company, as far as supplying the technical hardware and also allowing films to be sent to board-certified radiologists to be evaluated if need be. Vet Street's another part of the company, which is basically a practice management and marketing service for veterinarians to use. You don't have to be a part of VCA to be using these things. So again, it's just an effort to improve the general quality of veterinary medicine throughout the VCA realm of influence. VCA Kaneohe Animal Hospital was established in 1996. We presently have 9 doctors on staff. We are open every day of the year, just like Dr. Honma's practices, and we are open quite long during the day from 7 in the morning until 10 in the evening. Generally, we have 2 to 3 doctors on at a time. During the day, we may have as many as 4 or 5 doctors at one time. We are a general practice and also a surgical referral hospital. This is a view of our surgery room now. When I was making these pictures, I wanted to kind of show all of the monitoring equipment that we do utilize in surgery. We also have become aware that the dog's temperature or the cat's temperature during surgery is a very important consideration. So we have a couple of items here. This here is the what's called a hot dog, and this provides heated water through a pad that lays on the table to help with the warming. And this one here is Bear Hugger, which uses forced air in a inflatable type of, and I don't have, do you guys have these items here now, Bear Huggers or hot dogs?
No, we use like a hot water heaters.
Okay.
The mat, like a mattress style.
Okay, yeah. We use those a lot, but we found that they get punctured too many times and they don't repair very easily. So both of these things are a bit sturdier and they don't fail quite as often. This is an example of our table. I put this on there because I've been in a lot of practices where the table is basically just a table, and it does make it hard. It's nice to have the capability of tilting it in this fashion, especially for any perineal surgeries. Whenever you're in a perineal position with your animal, you always want to make sure you have good padding at the end where the rear legs are going to be hanging over. You can cause nerve problems if it's left there too long. You want to tie the legs loosely just so that they're not moving. And then also in this position, all the abdominal contents with gravity are pushing down on the diaphragm. So your anesthetist, whether it's one of your technicians or another doctor, very important to give that dog a good breath every minute. You know, don't rely upon the dog yourself to aerate his own lungs. So you got to help him with that. So intermittent positive pressure ventilation. Of course, the tables also can rotate to make sure that you have access to all sides of the dog. And they are hydraulic operated. Newer ones are electronic with a button. This has the foot pedal down here. You can pop it up. I'm sure you're all familiar with these too. Another thing that you can see in our surgery is that it is typically cluttered with a lot of equipment. Of course, during the day when the surgeries are going, a lot of that equipment is not in the way, but we do use it as storage. If you were to be making your own surgery room, you try not to use it as a storage area. Your surgery room should be somewhat sequestered, should have a door. You can see here we have acoustic panels on the ceiling. Not the best option for your roofing of your ceiling for your surgery. We just got new lights, which are very, very helpful. Your lighting is so important during surgery. And back here in the corner, right back there, is also a machine that has a fiber optic headlamp that in certain surgeries we can put a headlamp on to get direct lighting now. These lights have detachable handles so that the doctor can reach up and actually manipulate the lights without breaking sterility, and that's a real handy thing to have. These are monitoring equipment here. This is ECG, blood pressure, capnograph, also a pulse oximeter in all-in-one machine. Back here you can see our anesthetic unit here. In our surgery room we have 3 tables, and each table is supported by a wall-mounted anesthetic unit that stays with that table. We also have anesthetic units on wheels that we can move back and forth to other areas too. So it gives us a lot of versatility in where we can do things and when we can do things. This is our x-ray room. This is a digital x-ray. We've had it for a number of years now, and I can't imagine going back to film processing with films. Very versatile. We also have an anesthetic wall-mounted unit in this room so that if we have to take x-rays on an anesthetized animal, we can maintain the anesthesia during radiology. And so just a little bit of things about this, your surgical suite, the room, the table, the lighting, monitors. You can't monitor the animals enough. It's very important to have those things on. So all of our animals who are under anesthesia, they all hooked up to the ECG, they all have blood pressure monitors on, they all have pulse oximetry going on too. Most of our technicians want to also place an esophageal stethoscope in so that they can listen to the heart without having to use a stethoscope. And then personnel in your surgery room, limit people going in and out. Studies have shown that the more people that go in and out of your room, the more chance that you have of infection. So you want to keep the doors closed during surgery, and we try to make it a rule that anybody coming into surgery should at least have a mask, cap, and shoe covers on.
Shoe cover also.
Yeah, shoe covers also.
Shoe cover やってないね。
Quick thing about instruments. Of course, if you're doing surgery, you're relying very much on the quality of your instruments. For a lot of your instruments, you don't need to get the most expensive ones. Things like your hemostatic forceps, towel clamps, car mount forceps, blade handle. Those you can economize on, not necessarily buy the top of the line. For things that you're using all the time in every single surgery, it would make it a good idea to spend a little bit more money on those. Things like your scissors, mayos and medicine bombs, needle driver, and your thumb forceps. It's nice to have good quality instruments for those. They're going to last longer. You get less corrosion. Most of the needle drivers will have a titanium insert.
これニードルホルダーと同じね、箸器ね。
Yeah, so they don't wear out quite so much. Of course, every pack is going to have some gauze sponges, and we use a lot of paper drapes. We don't use as many cloth drapes. Some of the other things you might want to consider having on hand for your soft tissue procedures. A GI pack basically is the same thing, but it does have the Damien intestinal clamps, which are non-crushing clamps. If you don't have an assistant in with you to hold off the bowel to prevent leakage, those are good to have. A splenectomy pack basically is a whole bunch of the hemostats, because that's basically an exercise in ligation. Thoracic pack, if you do a lot of chest surgeries, it's a good idea to have a thoracic pack, especially if you do it on a big dog. The thoracic instruments tend to be a little bit longer, finer cutting edges, finer manipulation, and that's another indication where if you're going to be doing them quality of the instrument is very important. So don't try to save money on thoracic instruments. Balfour retractors, I'll have pictures of quite a few of these afterwards. Balfour retractors for abdominal exploratories and abdominal procedures help to keep the body cavity open so you can see things. The rib spreaders, there's lots of different types of rib spreaders. I have never found a rib spreader that's going to be applicable to the small dogs that we see. So usually with those guys, a pair of Gelpi retractors is good. Curettes, rongeurs, all are, they're cutting instruments. Rongeurs, especially with the bone, curettes with scraping things out. I use a lot of those in some of the soft tissue procedures, especially total ear canal ablations. A good pair of curettes to remove the epithelium from the osseous canal is very important. I like Alice tissue forceps just as something I can attach to the tissue I'm working on to help with retraction, so I don't have to always hold it with my thumb forceps. I don't get tired that way. I don't use them on thick tissues, usually on very thin tissues, because they are somewhat traumatic to the tissue, but they do come in handy to have a few of those in my pack. Various types of retractors, Gelpies, Wheatlaners are self-retaining, the malleable and the fork retractors you need in the system to help you with those. Some of the aids I found are very helpful in surgery that are not metal, not instruments. Gel foam is a hemostatic sponge. It's a cellulose derivative, slowly absorbable in the body. But if you have an area that's bleeding, maybe you've done a liver lobectomy, you've taken a liver biopsy with a skin biopsy punch, the gel foam helps to keep the bleeding at a minimum and does provide a scaffold for the capillary, for the platelets to hold on to improve your hemostasis. Lap sponges, of course, you want to use if you're going to be doing any intestinal surgery. You want to be able to pack off that area so that there's any spillage from your organ. It's not going to be affecting the rest of the abdomen. So we use those a lot. Whenever you use a lap sponge, always want to make sure it's moist. Don't put a dry lap sponge against the tissue. That dehydrates the tissue. It's very traumatic to the tissue. Sterile swabs, basically sterilized cotton-tipped wooden applicator sticks. I always have a pack of those available if I need to. They can be sterilized in a steam sterilizer in a bubble pack. I find those very helpful with working on the urethra because you don't really want to use a whole bunch of cautery to cauterize the bleeders when you're working in the urological system. So they're very helpful. They're fine tipped and they do absorb up the blood, and they are very helpful in that way. They also are good for if you're doing a pancreatic biopsy or something like that. You can use the cotton tip to gently paint your tissue away so that you can identify the area you want to remove. So just some pictures. This is our general spay pack. So if the doctor is doing a spay, this is basically what they'll have in there. We have a spay hook. Some people like to use spay hooks, some people don't, as long as you're careful with them. This one here is not one I like to use. If I do use a spay hook, this one has a little knob on the end. And I don't like that because if you're bringing up, you can maybe penetrate with that knob through the mesentery of the uterus and the ovaries. There are spay hooks that have more of a cut to it like that versus just a, and I don't know the names of those, but those are the ones I like to use. In here also we're going to have a couple of Carmont clamps, 2 or 3 depending on the size of dog. This looks like a small dog spay pack. We do have forceps. These are not my favorite forceps, so I don't use this pack very much. And needle driver here. I don't like...
It's no scissor.
No scissors. That's my personal preference. I don't like the scissor on my needle holder because I don't know if it's just because I'm not that good, but I always end up cutting my suture before I want to. So I don't like to use the scissors.
Do you have an assistant also?
No, not usually. So I usually do
By
this
yourself?
By myself, yeah. So that's why I like to use the scissor, the Olsen Hager needle drivers. And then what else? The blade handle. I was surprised by one of my newer doctors. He didn't use a blade handle to hold on to attach his scalpel blade to. And the reason he said that is because the first practice he worked at didn't have blade handles, so he always had to hold on to the blade with his hands. To me, if you're holding on to your blade with your hand, you really can't see what you're cutting. So you want to kind of keep your hands away from the field so that you can actually see what you're cutting. So I would recommend always using a blade handle. This is the pack that I generally will use for most of my procedures. It's basically the same as the spay pack. I have 2 different lengths of my Metzenbaum scissors for the fine dissection, 2 different lengths of the Mayo scissors for the less fine dissection. I have 4 small towel clamps and 4 large towel clamps in there. Not that I use them on every procedure, but if I'm doing an orthopedic procedure, and when I hang the leg for the prepping, I'm going to put 4 towels around, clamp those, and then I'm going to follow that with 4 drapes and clamp those to the previously draped. So I have those available in there too. I tend to use a longer needle driver than some other people. And then I do have an increased number of the hemostatic forceps in there, and also 4 of the Carmelts. I don't know if you all use the Carmelts a lot in your spays and neuters. The good thing about the Carmelts is if you look at all your hemostatic forceps, if this is the working area of your forcep, the hemostatic forceps, they all have striations in that direction. What the difference with the Carmelt is that at the tip of it, you'll also have striations in this direction. So that more efficiently prevents your vessels from slipping out of the clamp. And then the other thing that is important, which I tell all of the newer doctors that work with us, is no matter if you're using a Carmel or any of the other hemostatic forceps, you always want to use the tip of it. Don't try to clamp things with the base of the clamp, because that's not where it's holding well. They're always at the tip. These are the cotton tips sponges. They sterilize very well, and usually they put a big handful into each bag. So it's good to have. You may not use it more than maybe even once a week or once a month, but when you need them, they're really good to have. These are Balfour retractors. Now these are Balfour retractors. They're like that big. So these are ones that we were able to find that is applicable to the small breeds. So we have the larger ones too. You all probably know it, but everybody always asks me what this part is for, the spoon part. And that's if you're very cranial in the abdomen, the spoon part will hold the fat, the falciform fat out of the way from the front part. And it attaches to the main Balfour through this little wing nut thing there. Okay? You do want to cover the ends of your Balfours with a moistened gauze just to protect the tissues that are being retracted by it. This is an example of a Gelpie retractor. You'll see down here, a lot of the Gelpies when you buy them, they have a sharp point. This one I bought specially for more spinal surgery. I like the blunt point because I'm usually putting those into a deeper hole, and it has a longer length of it here, which goes downwards, so that it lays on the body, and I don't have the instrument all the way in. And these I had to have ground down afterwards. Most of the Gelpies you buy are going to have sharp points, so that helps me with the spinal surgeries. This is a malleable retractor, also called a ribbon retractor. And they're nice, especially for the abdominal procedures, because you can bend them to whatever shape you want. And so they're very versatile in that way. Just a series of curettes of various sizes. They are sharp on the end, so be careful. Okay, so suture materials. This is pretty much the suture materials that I use. Nylon, Proline are the 2 non-absorbables that I tend to use. Nylon mainly for skin. Proline I use for my gastropexies because it's non-absorbable. It'll stay there forever and is very, very strong. The monocryl and the PVS are the non-absorbables that I tend to use. Monocryl is a newer suture material. I like it very much. It is braided, which is not the best, but it's coated. But the reason I like it is because it doesn't stay very long in the body. Its strength is severely compromised a week after surgery, and it's pretty much not effective a couple of weeks. So I don't use this anywhere where I want the suture holding to be long-lasting. Generally, it's going to be used in my hands basically for superficial subcutaneous sutures, for intradermal sutures, and also when I'm doing a urethrostomy, where I suture the urethral mucosa to the skin because I don't want that to be there too long. PDS is probably the biggest workhorse in my hands. I use a lot of PDS. It has a holding strength that decreases only about 14% after the second or third week. Even 2 months down the road, it still has about 70% of its strength. So it's going to last a long time for you. I use that primarily in my joints, both for the joint capsule and also for the fascial covering of the joints. I do also use it as a transfixation suture for my ligatures. If I am doing something like a mammary gland tumor removal where I have a deep hole, I will use large gauge PDS, either 2-aught or 3-aught, as a deep closing layer to both to bring those tissues together and also to take the tension off of the more superficial suture lines. Generally, if I'm doing a mammary gland tumor removal, I have at least 2 layers of subcutaneous closure. More often I have 3 layers just to hold those together. And chromic gut I put on there. If you go to a school these days, if you talk to any board certified surgeon, nobody likes gut suture anymore. And for good reasons. It's reactive. It doesn't last long. It's taken away by the body via inflammation versus hydrolysis like the other absorbables. I use it either on a reel or in a ligapack only for ligatures. And the reason for that is because it's got, as far as my experience goes, much better knot holding capability than any of the other sutures available. I think the only one that holds knots better is silk, but we don't really use silk, and silk is actually kind of hard to find these days. So I use it pretty good size, number 2-aught and 2-aught. With that, I will have no problem tying off an ovarian pedicle in a 150-pound overweight obese mastiff. It holds on and it doesn't tend to fray on me. So I feel very secure with chromic gut as my ligatures. Needles, there's lots of needles available. Usually I'm using a reverse cutting needle or a taper needle depending on the tissues. The reverse cutting needle is good. Okay, so if you look at the end of your needle on a reverse cutting needle, it looks like that. The point would be right about here, and your cutting surface is on the back side of the needle versus on the inside of the needle. That helps to ensure that the hole that you're putting into the tissue with the needle doesn't enlarge more than you want it to. If the cutting surface is on the inside, as you put it through, no matter if you don't put any drag on it, it will cut the inner part of that arc and make your hole bigger than what you want it to be. Taper point needles, not as much use in my hand, although we do have the taper cut needles, where it's a taper needle for the majority of the shaft of the needle, but at the very tip is a cutting capability. So that allows you to get through those dense sutures without pushing so hard, like you would.
角芯と丸芯のね、角芯のとこの切れていく角度が膝なんかに針入れた時にどんどん切れちゃわないようにそれがまっすぐになってるやつとあるけれども、丸芯だけだとやっぱり入っていかないんで、角芯使うにしても逆にこうなんていうのかな、傷まないように向こう側に入ってるやつがあるってこうね、まっすぐに入ってくるっていうか、うちは全部それで、反対に切れるやつは使ってないよ。
Okay, so let's go on to just a real quick for the patient care. Preoperative things, of course, blood work, urinalyses, clotting profile. I don't do a lot of clotting profiles, mainly for dogs with liver disease. But the lab that we use, the Antec lab, includes clotting profiles in a lot of our procedures. My personal experience is you don't see that many dogs with clotting issues, so I don't always test for that. If you're ever concerned, that you have a dog that might be a bleeder and you don't have the availability or the results of a clotting profile, you can do a mucosal bleeding time, which is very easy to do. You just make a small little nick in the gingiva of the cheek of the gum, and with a blotting paper, just blot the blood away without actually touching the incision you made. Should clot within 2 to 3 minutes if it's not bleeding, and that's a good way to check to make sure you have adequate clotting in dogs. Of course, radiographs, ultrasounds, all those things are going to be done prior. Pre-anesthetic, I think, is very important. Proper pre-medication of these animals allows the induction to go a lot smoother, and just as important, or even more important to me, is that the recovery is a lot smoother if they've had a pre-medication. Typically, I'll be using a combination of a sedative like asapromazine and a narcotic. I use morphine a lot. Morphine is very cheap, very safe for dogs, and has a good wide dosage range. The doctors at our hospital, being more recent graduates, they use a lot of hydromorphone and buprenorphine, so some of the newer narcotics that are available. They're all good. They all do what we want them to do. Dosage is a little bit different. Cats maybe have a little bit more problem with the narcotics, so you got to be careful with the cats, but they seem to handle the buprenorphine very well. During the pre-anesthetic period is also a good idea to start your antibiotics and your non-steroidal anti-inflammatories if you're going to use them. At VCA, we've been asked to not use the NSAIDs until after the procedure is done. The concern there is that as you anesthetize the animal, you can pretty much assume, no matter how much you try to combat it, that you're going to get a decrease in the cardiac output. The feeling by the medical director of the entire VCA hospital organization is that it's best to not have an NSAID on board if you're going to have even a little decrease in your renal perfusion. So they recommend that we give the NSAID upon extubation. I know a lot of places, and I know a lot of doctors who will give the NSAID prior to the surgery. It's actually going to be more effective that way because you're providing the anti-inflammatory properties before the trauma is done to the animal, and it's going to be that way it's more effective. I don't think either way is wrong. I think you're safe enough, especially if you have your animals with fluid support during the surgery, the NSAIDs prior to the procedure are fine. Antibiotics we typically will use, not on every procedure. Most of our spays and neuters don't get antibiotics injectable. A lot of the other ones do, and I try to stick with a perioperative antibiotic schedule, give an antibiotic at induction, and usually I'm using cephalexin, a first generation cephalosporin, and I'll give 2 more injections at 8-hour intervals after that. Unless I have significant any contamination in my surgery, or I'm concerned about the quality of the animal's skin as far as infection, typically I don't send home antibiotics with the client. But almost 100% of my surgeries get sent home with at least an NSAID and sometimes a narcotic. I also use fentanyl patches quite a bit. And there is a new product, it's called Recuvera. It's fentanyl topical transdermal solution, which sounds nice. I don't like to use that one, primarily because fentanyl being a narcotic, some of the dogs I send home, they become dysphoric. The owners are not happy just with their mentation. They may be vocalizing inappropriately. If the client calls me a day afterwards that's what's going on, they just are real anxious, I'll have them take off the fentanyl patch. And typically within 6 or 7 hours, the dog is back to feeling normal. I've lost the pain control of the fentanyl, but at least the animal is not causing so much consternation for the owners. With the Recuvera, when you put that on, it's there for 4 days, no matter what you do. It can't be washed off. And so the first couple of times I used it, I didn't like the response to the animal based upon what the client was telling me. So I'd rather use a reversible product, so that's why I use a patch. After the pre-anesthetic, we typically will walk the dogs to give them a chance to urinate or defecate. Certainly the technicians like that because they have less pee and poop to clean up afterwards on the table, but it helps to prevent that kind of stuff going on. Induction. right now, basically I'm using propofol for everything. We just got approved in the States for the newer injectable induction agent, alfaxoliner, as I believe it's called. I haven't used it yet, but I'm looking forward to it. It also is applicable in cats in a subcutaneous fashion and will achieve a surgical plane so that you can intubate the cat. So that's very nice if you can give a cat a subcutaneous injection. Wait a little bit and you'll be able to intubate them. Mask or box induction, not used quite as much if I have a fractious cat who's going to tear my face off, any kind of handling. We'll put those guys in a box and pipe in the isoflurane to them. When I first got to VCA and was working there, all of the animals were induced by a mask, and that is, to me, not good. For one thing, it takes a lot longer. You need a lot more staff to hold those animals, especially when they go through the excitement phase, and it's a big stressor on the animal. So I try not to use mask induction at all. Intubation, of course, very important. Unless it's a very small animal, you're going to need to use a cuff tube. The cuff tube, of course, seals the airway, so you don't have any chance of aspiration. Dr. Katsumi asked me to comment upon how far you put the tube in. When I place an endotracheal tube, I want to place it past the larynx, but I want to stop there.
喉頭蓋ね。
Yeah.
喉頭蓋のすぐ後ろのところまで入ってれば、気管チューブの位置はまあ十分でしょう。
Yeah. I have seen cases where the intubation tube was too long and it actually intubates into the left or right mainstem bronchus. So your animal's not going to stay under because only half of its lungs being aerated and only one half of the lung is being provided by oxygen. So make sure that you don't place the tubes too long. If you're not sure if you have an animal you've just intubated and it's not staying down, you're wondering if you actually made it into the airway, palpate the neck. If you palpate the neck, you should only feel one firm structure, which should be the trachea. If you're feeling another firm structure in there, that's probably the endotracheal tube in the esophagus. And so that helps. Otherwise, you can look down the mouth and see too, but if the animal's on its back or on its side, it can be hard to see that. One thing the technicians do to figure out the size of the tube, and I didn't notice until I saw them do it, they will take the end of the tube, the end that goes in, and they'll put it up against the nose. If it covers the philtrum of the nose but doesn't go all the way to the alar cartilages, then that's an appropriate size for that dog.
Oh yeah?
The endotracheal tube. Yep, seems to work. Just measure the tip of the nose right at the tip of the tube right at the nose. If it just covers the philtrum and a little bit more than that, then you can...
to nose to where to where?
So...
diameter, right?
Yeah. Yeah. So here's your, your dog's nose, right? And you got the little midline there. So we'll put the tube right here to see. So if it covers that, that's an appropriate size tube.
Oh, even short head or anything, basically.
Anything.
Wow.
Seems to work. Yeah. And of course, after intubation is when you're going to be doing clipping and prepping. And I'm not going to go through a lot for that. Just that we, in our hospital, on the table that we've anesthetized the animal, we'll do an initial clip. If the animal is very dirty, we'll do some prep there. But once we get into surgery, the technician will put on the peristerile gloves and do a sterile prep in surgery.
So, doctor, maybe some point here, maybe you accept to please make a question?
Sure,
Yeah?
anytime.
そう、今9ページまでだいたい進んだわけですけど、すごくもうなんつったらいいでしょう、内容がいっぱいなんで、どれが質問って言ってもあれでしょうけど、まあ最初の半分はだいたいいわゆる VCA のカンパニーの紹介であったりとか、1年間のね、何ていうの、スカラシップっていうか、スカラシップじゃないね、インターン受けたりなんかっていろいろ言ってましたけど、それからあとはちょっと手術の用意から今ちょっと麻酔の導入までですかね、痛み止めもちょっと触れてましたけど、各論に入る前にどうでしょう、カニコムさんの会社の方とあるからなんか獣医さんから一つなんか普通の一つ二つ三つでも、もう今日はほんのベリーフュー Yeah, guest today. We have plenty of time. Question and discussion, please.
いいですか？
English is okay.
ちょっと私が英語で何て聞くかはわからないので、できれば
はい、はい、OK。
ハワイにおけるそのワクチンとか、そういう飼い主様のワクチンを打たなければいけないっていうところの
About the prevention service categories, the question from the insurance company vet. Okay, はい。
ワクチンを打つっていうことに対してハワイの皆様の意識っていうのはどの程度のものなんですか？
So, how much percentage is the coverage by the vaccination, like a mixed kind, rabies, or totally? Of the, how do you think your VCA and all the Hawaii?
You mean
The prevention about the vaccination, vaccine, like
coverage?
hepatitis and the parvo and distemper, the mix, right?
Yeah.
How
So
much?
you
Everybody?
asking the coverage by the insurance company or our vaccine
No,
protocol?
all the owner
Oh, okay.
has,
Well,
including all Hawaii, even country to Honolulu.
well, if I understand your question correctly, our vaccine protocol when the puppy-
Because it's not the law, right? It is not under the law. Yeah.
No, we don't have any requirement
Yeah,
for rabies
yeah.
vaccination in Hawaii because we're
Yeah,
certified rabies.
because the Japan, even we had a very strict law for the rabies,
Yes.
but it's only less 60%.
Oh, really?
Yes,
Oh,
and also mixed kind is like a 40, 50, 60, but very difficult to continue to the vaccination shot, to continue to second year, third year, or
Right,
sometimes
right.
like a previous years. So,
Yeah,
so
okay.
how do you think? How much about the percentages coverage?
for our clients, I would say it's close to 100%.
Yeah, about adult size and also puppy. So
Yeah.
please make a 2 answer, please.
Okay, so our general vaccine protocol, both for cats and dogs, as kittens or puppies, is we want to see them at 8 weeks, 12 weeks, and 16 weeks of age.
The 3 time.
3 times as a puppy. The first visit for the dogs, they just get the distemper and parvovirus combination. Also has an adenovirus in there too, the parainfluenza. For cats, their first visit is just going to be the
3 core vaccine, right? 3 major core.
Yep, so it's going to be the rhinotracheitis, Kalichi virus, chlamydia, and the, what's the one, well, it's basically the...
Parvo, adeno, and the distemper, right?
Yeah, yeah. So then at the 12 week is when we introduce for dogs the kennel cough vaccination, and we introduce...
5, 6, 8, something like
Yeah,
that.
and we introduced the leptospirosis vaccination. So in Hawaii, we actually lead the United States in leptospirosis cases in humans because our streams they are infected with it.
レプトシス
Leptospirosis.
ハワイは結構レプトが出てるもんですからね、人間の方でもね。
Yeah.
アメリカの輸入っていうか輸入持ち込みの時もレプトのあれは完全に必要です。
そうですね、抗体ちゃんと上がってないといけないからね。
So we don't vaccinate for coronavirus in dogs. And then the 16-week visit for the dogs is a repeat of everything. And then after that, we get them back 1 year after that date for their first annual checkup. And we will repeat all the vaccines at that time. At that time, we start once every 3 years with the distemper parvo combination as a core vaccine. And the leptospirosis and the bordetella or kennel cough is still yearly. We do base that upon the dog's lifestyle to a certain extent. A lot of our dogs pretty much either are in the house or in the owner's yard, and they don't go anywhere else beyond that. So for those guys, maybe don't need to have the kennel cough done every year. Leptospirosis, not a problem for that dog. So after that first annual checkup, we base a lot of our vaccine protocol on the dog's lifestyle. But they will get once every 3 years the distemper and parvo combination. We typically will stop that as a senior animal. So for me,
Senior means how much old is the border?
depends on the
8, 10 maybe?
Yeah, 8 to 10.
So, but the doctor, it is not the mandatory things, right?
No, it's not
So,
mandatory.
but American pet owner can choose to including a rabies vaccine shot, right?
Yes.
By the malaria or something like a billback, something like that.
Yeah.
So, how much percent? Because our question is very basic. Because if the Japanese owner doesn't have a chance to go visiting the pets, sometimes they don't vaccination. But how the American people, everybody knows to this kind of a basically schedule, everybody knows?
Yeah, I think, well, it's a little bit different for us regarding rabies because we're rabies free, so we don't have to vaccinate. But on the mainland...
Also Japan too,
Yeah.
no rabies, but we have a law, mandatory
Yeah.
law.
So I guess it depends on how they enforce it. My impression is that on the mainland, if you want to have your animal licensed by the government, state, or what have you, they will require proof of rabies vaccination.
It's kind of like a breeder things, like a show people, because for the license from the animal holder.
No, the local city license, city and county license.
Okay.
Yeah.
They need.
So they need to provide proof of.
It's someplace.
Yes.
Okay. So how much percent? How do you think? Everybody has vaccine.
100%.
For
100%.
for rabies or for the other
Or
vaccines?
the others mix and rabies also.
We do pretty good with our clients as far as making them adhere to the vaccination schedule. And I think it helps us because it wasn't more than 4 or 5 years ago that all the vaccines were given every year, once a year, no matter what. So now that we've been more dependent on the lifestyle, and we've considered that the distemper and parvo just once every 3 years, we get a lot
Yeah,
more.
it's a lot of different opinion, right,
Yeah.
about this
Yeah.
schedule, right? So, why she has a question, it maybe the Hawaii and the mainland usually insurance coverage percentage is 25 to 30%, right?
Yes, of our clients, I would say,
that's like average, yeah?
Yeah.
Maybe big cities more, right? So, but in Japan, there are especially animal, there are many veterinarian doctors working, more than 100 doctors working. So then they are more looking for more exactly prevention covered, keep healthy, yeah? Because then their lost money is more or less.
Yes.
Yeah?
Yeah.
So that is the point for the how much percentage is like a prevention check or checkup or something.
Yeah.
If doesn't no information, so to the client, Japanese people are maybe so my clinics are many local side, right?
Right.
Major city, but it's local side. So then first year 80% vaccine, but the next year, third year, something continuing repeating the customer is 40. After 8 years old, somebody has a different opinion, so some client, then more or less, then I understand. But actually, heartworm and also mixed vaccine and the mandatory of the rabies, it should be 100%, right?
Should.
Yeah. But even we make a contact telephone or email, but all the Japan veterinary average is maybe 40%.
So do you do heartworm prevention? Is heartworm prevalent here in Japan? Heartworm disease?
Heartworm?
Yeah.
Yeah. But now almost we are 90% control because 60-70% people doing the monthly care. But people not so much exactly continuing because they have many researching, right?
Yeah.
So then 35 to 40% people is kind of maximum.
Okay. So, well, as far as that goes, one of the drivers that we have for that is we require a valid heartworm test every year. If they don't have a heartworm test that year, they can't purchase the heartworm preventative, nor will we write a prescription for them. So they have to come in for the heartworm test every year, and that's how we get them in to do the vaccines.
Recommended to by veterinary hospital?
Yep.
To phone call or email or they give the paper?
For the prescription?
Yeah, prescription not information.
Oh, I
give-
see.
Yeah, because they forget or sometimes they don't like this.
We try to instill in the client's mind those things during the puppy series.
Puppy.
They're doing the first 3 visits, the 12 and 16
that's
weeks.
it.
We try to give them a rundown of what to expect as the time goes on. And I would say most of our clients are pretty good. I don't think we have 100% as far as vaccines when we want them to, but I would say
特にハワイの場合はヒューメンソサイエティとかRCPA って動物愛護団体の影響がすごく強いですから、全米的にそうですけど、やっぱりそういうところから出るインフォメーションのそのいわゆるスタンダードの部分がすごく強くやっぱり影響してますから、その彼の答えが僕がこういろいろくどくど聞いてもなかなかパーセントが出てこないというのは、意識しなくても来てると。だからそこの部分が今日本がそのペットショップがやろうとしてますけど、獣医もやろうとしてますけど、それがいわゆるそのビジネスピッチにどうしてもお客さんから聞こえちゃうところもあるんじゃないかというね。その件でだから公衆衛生的意識っていうのをもうちょっと僕らも、だからうちの会社なんかもすごくこういうセミナーをねもっとやろうとしてるわけで、その件ですね。そう、他に何かありますか。 Thank you very much, Doctor. Yes. そしたら小森先生。
How many clients do you have at your Kaneohe hospital daily?
daily. Depends on the day and the number of doctors there, but I would say, well, on my days, if I'm full, I'm seeing appointments. I have availability for about 30 appointments a day. Plus, I do surgeries most days of the week. I would say we daily see at least maybe 100 animals.
100.
Yeah. Yeah. And that's probably average. Some days not so much, but most days more than that. But that's spread amongst a number of doctors.
All of those patients has to make an appointment.
Yeah, so we mainly appointments, but we also do take walk-ins. So you can come both ways. And we try to also do drop-offs, like if a person wants an animal looked at, the drop-off in the morning gives the doctor a chance to look at the animal during the slower time, and then call the client back. And we don't do as much of that, but I like that idea.
You said you have 6 doctors at your hospital.
We have a total of 9 on staff.
9.
At any time, we have anywhere from the late hours, maybe just 1 doctor, but during most of the day, there's at least 2 or 3 doctors there. During the busy parts of the day, we have 3 to 5 doctors.
So it depends on the time. Yeah. And well, your hospital starts at 7 to 10. What is the shift of your doctor? Shift? 7 to 10?
No, our doctors are generally scheduled for 10-hour shifts.
10 hours?
Yeah. So they get a 10-hour shift, and 1 hour is given to them for a lunch break, but usually a 10-hour shift.
10-hour shift.
So I work myself. I work Monday, Tuesday, Wednesday, and Friday.
Monday, Tuesday, Friday.
Monday, Tuesday, Wednesday, and Friday.
Monday, Tuesday, Wednesday.
So it's nice because you get the 3 days off during the week.
3 days off.
Yeah, 3 days off.
Always.
彼は前に部員長をぐっと忙しくやってて、この何年かそういうポジション少し顧問的に今下がっているというか、外からで手術ばっかりやってるんです。
I'll be working from Monday through Sunday.
Monday to Monday.
Me.
No, I think you need to talk to your boss.
それでね、トータルで彼のとこはこの9人だったでしょ、メンバーが。で、大体6億円やってます。年間売上6億円。だから、like 5 to 6 million dollar sales, right? だいや、そう。そう。それで、じゃあ、柴田さん。なんか、この、ちょっと今、手術の前まで行ってたよね、ちょうどね。
通訳してくれるから。
いいよ、言ってくれればいいよ。
逆に期間中もこれ以上入れるといけないみたいなありますか。
喉頭蓋のとこまでって って彼言ってたよね、すぐ後ろ。
普段はもっと奥まで入れます。
Okay.
So, if you explain to exactly how much to trachea tube after the
Just far enough that you get the cuff passed. Once the cuff is passed, it's far enough.
after the cuff,
Yeah,
the cuff of the tube, right?
right. The cuff. Once that.
ああ、
once
カフ
that
がついてるじゃない途中に。あれよりもグッと入っときゃそこのところだよ。
so your endotracheal tube is probably going to end maybe mid-thoracic.
私が普段入れるときに多分先端が多分この辺まで来てるかと思うんですよ。
測るとね。
それはあんまり良くないです。
So usually Amy same actually. So to the trachea tube to put it to the trachea, right? So look at it's exactly like here. It's maybe it's too much deeper.
Maybe too long.
Too long.
Yeah.
手前の方がいい。
もっと手前。Just after the cuff. あとコート外とか。コート外なんすか。
Yeah.
コート外。
Once the cuff clears the larynx, that's when I stop. And then I tie it.
カフの位置で見るのもあるけどさ、彼ちょっと僕コート外にちょっとなってきましたけど、コート外のすぐ後かんとこだとさ、もう大丈夫だって言うんだよね。
結構ここ口から結構長く出てても問題ない。
Then feeling like maybe this much to jerk it
coming
out. Yeah.
Okay.
And the fix to the stopper, right?
Yes.
Yeah.
So-
Bite block.
Yes.
Through to the usually are you use oftenly bite block also?
No.
No. Yeah, we same.
No, what we do to stabilize our tubes.
Yeah.
is we-
Epiglottis. After the epiglottis, right?
Yeah. Well, your epiglottis is in front, and then you have your rib.
Yeah.
And so as I go past, as soon
Yes.
as the cuff gets past the larynx, that's when I stop. And
割とあっさり入れてるのよ。Because we very actually all the Japanese doctor little bit concerned about the out because sometimes when like this, yeah, and the tracheal tube is not enough in case the feeling like something to the back to the lungs because it's going miss throat or something.
But I think that kind of is if you get the tube in
Go in.
just past the larynx, you want to tie it right there, and you're going to have the animal under, so hopefully you won't be coughing to force the tube out. We use in our hospital, you know, your IV lines that have already been used. We save those. We cut those into lengths about that long, and we use that to tie the tube. So we put a knot around the tube itself in the mouth, and then we'll wrap that around the nose and tie that on top of the nose.
紐でね、僕らもそうじゃん。紐で絞って鼻のとこでこうやってるので、時々切っちゃう短く。So it's basically it'sなんだっけ disposable?
The tubes?
Yeah,
Yeah, they are.
disposable.
Yeah, but we don't dispose. We use them over.
We
and
use
over.
not disposable.
Yeah.
Basically, but we make all the sterilize again.
Yeah. Well, we don't sterilize our tubes.
Oh yeah, flush like washing.
We just clean them. Yeah. They don't. You know, your trachea and your mouth is not a sterile area, so it doesn't really. The only time we use a sterile endotracheal tube is if we're doing like a bronchoscopy, where we want to take some bacterial samples or cellular samples from deep in the lungs, and that way we want to have a sterile tube. But most of the time, the tubes are not sterile. And then another thing about the endotracheal tube is when it's in, if you have to reposition the animal, change them from one side to the other, you always want to take the tube off, detach it from the machine, reposition them, and put it back on. If you twist them with the tube still attached, you might cause the tube to twist inside of the trachea, and especially if your cuff is enlarged, that could cause some damage to the trachea. So we always
Because we concerned for about very small, short nose dogs. A lot of coenzymes and throat like what's the accidental ingestion.
Oh, yeah.
Like a coenzyme style accidental ingestion. So yeah, misthrowing, kind of misthrowing, but actually it's It's accidental ingestion, formally.
スローイン
Yeah, like
どっ
this.
ちもどっちも
From the endotracheal tubes.
No, actually, from that, it's a reason, because like this, this,
I'm not sure I understand.
because it's not the foreign body things, okay? It's a not the foreign body things. So it's like a lung inflammation.
Okay.
Lung inflammation, right? So because the trachea tube is one of the like foreign body, right? To in. So even pre-anesthesia timing, so many short notes dogs are like this, and also through to into the smooth to exactly position. So then it's like a isoflurane like a 2.5 to 3 percentages and very stabilized. But actually if too much short to the trachea tube, so in this like in this point very sensitive like
Oh, I see.
yeah to
Yeah.
between to the cuff position.
I see.
That is our experience actually.
Okay, so maybe what I would say to that, if I understand correctly, is that once you get the tube in, you want to turn the gas up high so that you get them under pretty deep before the cough reflex is there. And also will help with your induction agent to make sure that you give them enough of the propofol to...
Yeah, we use all the time propofol first.
So I haven't had a problem with that in my brachycephalics. With the brachycephalics, when I extubate them, I want to make sure that they're very awake. So typically we'll wait until the dog is
Yeah,
trying to
because
chew.
sometimes they are like a corruption doggies. Yeah, like a Yorkshire Terrier and the Chihuahua has sometimes it's very narrow like a collapse.
They've had a debark done?
Yeah,
those
exactly.
are hard, yeah.
Like this.
Yeah, so it's
This
hard.
case, because Japanese toy size is only 5 pounds.
Yeah.
Oh my God, so small.
Yeah.
Like this, like this.
Okay.
Oh yeah, that's
Yeah,
why.
so I think you-
So you make more deeper.
Yeah, you want to make it more deeper before you try to put the tube in, and that will help that. And of course, with the brachycephalics, they got so much tissue in there; it's even hard to see. Yeah.
Are you use sometimes xylokines? 2%, 3%, 4% xylokine, local anesthesia?
For the cats, mainly for the cats.
Cats only.
We don't tend to use it for the dogs.
But we use usually xylokine でしょ? Not so much use anymore? Not so much use.
何もそのまま直接
直接入れる。
でも
OK。
その後はシュして
なるほどね。
Yeah, sometimes with the cat's hard because you have to. It's tight.
Yeah, very tight.
Yeah, very tight. You have to wait till they open up, and then you get it in real fast. So you use the lidocaine on them.
でちなみにね、彼の説明の中で滅菌がありましたけど、やはりもう今ガスはやはりアメリカでももう禁止だもんですから、ほとんどもう今はエチレオキセイトガスはやってなくて、オートクレームでやってるそうです。であとちなみにアニコムさんの関連してるあそこジャスミンさんも前に野口先生見せていただきましたけど、アニコムカンパニー has one of the relation of the heart surgery special hospital in Tokyo also. There is also same steroids or the alcohol with a special like autoclave things. Even heart surgery.
Oh yeah.
No gas anymore. No
Okay.
gas.
No gas, yeah. Most of our instruments we use as steam sterilization.
Yeah, steam 蒸気滅菌ね、なってますね。それからあと麻酔に関してはあれでしたね。やはりアイソフロレンがほとんどで、もう今セボフロレンがちょっとエキゾティックペットでやってるくらいで、やはり日本と同じようにほとんどもうアイソフロレンでやってます。それからあとマイナーサージェリーの道具がさっき写真でたくさん出ましたけど、大体我々と同じですけど、彼のところみたく大きな世界で一番大きな動物病院でも 彼一人でほとんど手術やってるっていうのは結構びっくりで、日本、まあ、もちろん大学式とプラクティスは違いますが、今日本でちょっと実際に、まあ、ここで本当はいっぱいドクターがいればいいんだけど、まあ、いないでしょうね。要するにいっぱいスタッフをいるというふうに多くの先生思いますけど、決してそんなことはないです。アメリカの最先端でやってる先生方っていうのは結構きちっとこじんまりやってますね。だからリアルな部分をもうちょっと見てないかと、日本はとてもコストがかかってしまって料金にチャージできてないっていうそういう部分にぶつかっていると思ってますね。So I explained them many Japanese doctors now thinking, we need more staff, we need more staff for the surgery, but actually in the front of the practitioner like you, so it's very much compact, but exactly focused to the safe surgery.
Right.
But this is the very basically things actually, but very important. Yeah, and also we are now in this 5 years a big investment turning point for the digital things like X-ray and many things to change the digital things. So how do you think now? What is the most big changing for equipment now? Do you have something changing point now, or not so changing? Because it looks like VCA like. Surgery light changed, but other things in these 5 years changed to basically to analog to digital, right? How do you think more CT scanning or something like a laser or endoscope? What is the movement now?
I think, well, it depends on different areas of the profession. I think the advent of the CT scanning and the MRI has made a big change. And now we have 3 different CT scanners for dogs and cats in Hawaii or in Oahu, run by veterinary practices. And we also have availability to have the MRIs done through a human hospital. So I think that's the imaging capability.
向こう結構貸してくれるのね、人間の病院がね、使っていいよって。だからハワイの人口120万人いますけど、ほんの最近の 2,3 年ですよ、CT が入ったのは。
And I think another big change that's gone on is the changing in the vaccine protocols. That's
vaccine protocol ね。More like a term, right?
Yeah, the concept of the core vaccines versus the non-core vaccines.
日本だと石田先生とかが最近この 2,3 年結構言ってるといえば言ってるし、まあ逆に言うと猫のワクチンなんかなかなか日本では浸透してこないんで、その辺も問題となってますけれども。そういうことですね。ワクチンに対するそのタームが、しかしその元っこにあるのはやるが当たり前っていうのと、日本みたく銃やペットショップがギャーギャー言ってもなかなかやらないというところとの違いっていうのもあるんだけど、まあ、結果としてはそのワクチネーションのプログラムについての前か。
The third thing I think has changed our profession a lot is the internet.
インターネット。インターネットエデュケーション or インターネットコミュニケーション to the client things? Both.
Internet education and internet miseducation.
Oh yeah, correct. Rumor.
Yeah, we have to combat that a lot in our clients because they think what they see on the internet is gospel truth. It doesn't really work that way.
So どうですか？何かあります？次に行っていい？大丈夫かな？ Okay.
Okay.
Please next. Page 9, page 10.
She's not. This is one of our technicians. She's not scrubbing it for surgery. She actually, we were making Christmas decorations. But
She looks like a Japanese girl.
She is. That's Erin Akiyama.
Oh yeah.
So, but I just put this up there. That's what we make our technicians wear in surgery. Okay, so we went over a lot of this already. With monitoring the temperature, making sure they don't get too cold. With the bear hugger or the hot dog, our monitors, we went over that. I will have all of my animals on IV fluid support, usually 20 mLs per kilogram for the first hour, and then half of that for every hour afterwards. Quite a few of them don't need the fluids to be given after surgery, but for the older animals or those who have medical issues, we usually will at least carry the intravenous fluid support till the end of the day. Talked a little bit about the hemostasis already. I use a lot of electrocautery. I'm kind of old, so that's what I grew up with. I know a lot of people are using the laser and also electroscalpels. Those also are very effective at minimizing hemostasis. My only comment for that sometimes is on with the newer doctors. They're doing their spay or some minor procedure, and they'll spend 10 minutes trying to make sure there's no bleeding at all. I think that's a little bit foolish because you're going to get bleeding no matter what you do. Most of the time the bleeding will stop on its own without any intervention on your part. So I would counsel you not to spend a whole bunch of time trying to stop every little bleeder that you encounter. The animals are tougher than we give them credit for. Ventilatory support, very important, of course, like I already mentioned with the dogs in the perineal positioning. Want to make sure that they get adequate ventilation. Even in a dog, especially for a long procedure, it's always a good idea to make sure that they get a good breath every once in a while. We take them up on our gauge to about 14 millimeters of mercury for that to inflate the lungs. When I have my technician breathing for me during thoracic procedures, typically they're breathing 5 to 10 times a minute, and I always tell them when they're pressing on the bag, think about your own breathing when you inhale and you exhale. Typically it's divided into 3 parts, 2-part inhalation, 1-part exhalation. It naturally just goes. So you don't go like that. So I have them compress the bag to the pressure, hold it for a brief second, and then let the animal breathe. So that helps to increase the lung capacity, also helps to fill it up completely. If they don't hold that inspiratory volume, then the animal is not going to get the oxygen because it's just not there long enough.
So what is the percentage of the ventilation support? The machine support? No, basically no.
No, only I don't use a mechanical ventilator.
Only the hernia for the chest parts or heart?
All of those, I have an anesthetist.
日本でも結構ベンチレーションを前提にずっとやってる先生結構っていうかたまにいますけど、基本的にはやっぱり気管チューブで自圧呼吸っていうのはまあずっと 90% の、まあ、メジャーな方法ですね、何にしてもね。ただやはりマスクだけっていうのは担当者とかまた元気っていうのは同じ認識ですから。You are actually basically 100% tube, right? But not the ventilation machine, not by the same.
Yeah, from minor small mass removals, our cat castrations, those are all injectable.
Only
Yeah.
ketamine or something.
Ketamine for the cats. Yeah. I like the do you have dexdomitor here? Domitor, the alpha 2 agonists for medetomidine.
Yeah. Metomedine とか、ね。
I like that a lot.
Very safe. Very safe.
Very safe. I don't get too concerned about the bradycardia. If I want to make it a little bit longer, I will oftentimes pre-medicate with something like butorphanol as a pre-medication.
Butorphanol, yeah.
So that
Betagonol,
yeah. So I get a little bit better sedative with that. I don't like the Domitor, the medetomidine, so much by itself around the head. They don't seem to stay down quite as well. They're still very sensitive to touching of the ears and also loud sounds.
Oh yeah.
Yeah.
Metomedine. Under the metomedine.
Yes.
Should be quiet.
Yes.
すごく大きく音がってなるんだろうねきっとね。
And after I give the medetomidine, I tell whoever's assisting me, holding onto the dog, to no stimulation, just be there, gentle touch. But don't go, oh baby. No. Just be there. Yeah, just to monitor it. Don't try to stimulate the animal at all. Okay, post-operative care, of course, you're going to be extubating. The timing that we use for extubation is when we can induce a swallow reflex for the dog or the cat. Sometimes I'll go jiggle the tube a little bit, and that will stimulate the reflex so we can pull the tube out. With the brachycephalics, we basically want them to cough the tube out themselves. Ice packing, especially on my orthopedic procedures, I do a lot of ice packing afterwards. What we do in our hospital is we take our 250 ml bags of fluids, maybe sodium chloride, lactate. Once the bag is empty and no longer being used, we will fill that up with alcohol, isopropyl alcohol, and we'll put a little food coloring in there, turn it red or orange or green or something bright, so we know that this is a ice pack. And then we'll stick that in the freezer, and hold that in the freezer. The alcohol in there will freeze, but it doesn't get hard like water, and so you can use that. It'll conform to the body surface that you want to ice, and it does hold stays cold quite a while. I will wrap that ice pack in a paper towel and moisten the paper towel, and then put that against the wound.
あんまり日本じゃこう冷やす療法ってその手術なんてやりませんけど、彼ら全部やってるっていうことですね。日本はほとんどやってないですね。
So my schedule for that, that I write for the technicians on their ICU sheet, is once every 4 hours. We want to ice pack the wound about 10 to 15 minutes. So they,
これすごく効くそうですよ。
and generally the animals tolerate it very well. Analgesia, we touched upon that a little. You know, these days there are so many analgesic products out there available for us, and our clients are in tune for pain control for themselves, mainly for themselves, but they transfer that to their animals. So I think it's bordering not necessarily on malpractice, but poor quality if you don't provide all of your surgical patients with some form of analgesia, at least for some period of time afterwards. For our spays and our neuters, they all get sent home with a 5-day course of a non-steroidal anti-inflammatory. For the animals who are undergoing orthopedic procedures, they are sent home with the fentanyl patch and a non-steroidal anti-inflammatory at the same time. We have a new NSAID for the cats. I'm sure you guys have it too. It's called Onsior. For us, it comes in 3-day packs. It's a chewable tablet, and cats are a little bit different. It's not as many NSAIDs are approved for cats, but this one's approved, and they tend to eat it very well. Temperature control both during the surgery and afterwards is very important. Though the bear hugger we use that a lot for temperature control in the cage during recovery. So we'll put them on a nice padded surface in the cage. We do have a couple of cages that have heated floors, but if we don't have that available for that animal, we'll put them on some nice padding, and then we'll lay the bear hugger on top of them to hold the heat in. And we want to check their temperature and keep them under support until rectal temperature of 100 degrees or higher. And of course that's Fahrenheit, sorry. IV fluids, of course, during the surgery, and then depending on the case, maintenance afterwards. Most of the spays and neuters, they don't get fluids after the surgery. They just get it during the surgery. Bedding, obviously you don't want to have them lying on a hard surface. We will provide towels or quilted blankets for them in the cage. And then we usually will use the initial post-operative period to fit them and place an Elizabethan collar just to prevent self-trauma to the wounds afterwards. It's especially helpful with those bad dogs because at least you have a little bit more protection with the Elizabethan collar on them. And then it's important, of course, when they go home that you send home concise and clear instructions for the client. We have a form that we use that we can fill in various things that we want them to do. But you really want to hand your clients something that they can look at to help them after the surgery. If you just give them all those instructions verbally at the time of discharge, they are too excited because they get to take their animal home. They're probably not going to listen to you, and they probably won't remember anything you told them. So it's nice to have all this stuff written down for them. Any questions as far as this kind of stuff right now?
何か質問、何かっていうか、どうですか？同じパターンでまた。
Do you have some combat cases with your client, especially in the case of some kind of accident bears. Yeah. Do you have some combat cases with your client?
Combat, like a trouble.
Fights.
It's a final position.
Yeah.
Oh my God.
Oh, that's tough. That's tough. I don't know.
But do you take agreement, right? Very strong paper agreement.
Yes.
And also the introduction to we say counseling, right? Consultation, right? Yeah. Informed consent, right? Informed.
Yes.
Enough, but no trouble.
Not all the time. I mean, most of the time everything's fine because we provide them with a financial estimate. Because a lot of the conflict is because of how much money we're expecting them to pay.
It is the paper.
Yeah, so the estimate is very important. And I try to give the client an idea of what to expect when they get the animal home. Yeah. Even with that, though, oftentimes our clients who are mad, if I have to have that kind of discussion with the client, I try not to say too much at all. I want them to get all that out. I don't interrupt them. I try not to get defensive and bring my own personal feelings into it. Because if I get mad and they're mad, it's just going to escalate from there. I try to put them in a room, take them out of the waiting area, of course, put them in a room and sit down and try to give them the feeling that I am listening to their problems. I am concerned about their problems. I validate it with them so that they hopefully get the feeling that I'm there for them to help them out versus just trying to take money from them. Your quality of care makes a big difference too, so the less mistakes you make, the better. If a mistake is made, my feeling is to tell the client, let them know. I don't want to lie to a client. I want to be as honest as I possibly can. Some insurance people have told us, don't ever say you're sorry. Because saying you're sorry could be taken as an admission of guilt. That's kind of different. To me, saying you're sorry is more saying that I feel for you. I don't like what you're going through any more than you do. And I wish it was different for you. So I'm sorry that you're experiencing this. Whether it's my fault or not, that doesn't come into the statement of yours. I'm sorry.
Do you have a different agreement paper of each different surgery? Like a totally no risk, like a castration or spades, maybe only the one simple paper, example. Or something like a heart surgery is maybe 3 paper need to agree.
No, they're all the same one. They're all
Same.
We have the client information at the top, and then we have a list of the procedure. So we can write in whatever they're going to go through that day.
ちなみに VCA さんのその同意書っていうのは僕もうすごく昔にもらってきましてね、ずっと研究してたことがありますけれども、非常によくできてますね。Because I saw before the VCA the agreement paper.
Right.
Lots of sentence kind of, but not so many.
Right.
Yeah, only one. Yeah? I remember. But now I have a question also because you have so many different type of the surgery, right?
Right.
Yeah, especially like a kind of a cosmetics, like a bone surgery and some of the cosmetic things. So that's why. So I wonder. So you have a different paper. Also. It's basically simple. One.
Simple, yeah.
One grade.
Because all the things that we expect from the
If we have a
client-
chance, please send Dr. Komori
Sure.
to the new one.
I'm the only expert court fighting.
Oh, okay.
Yeah.
Oh, that's not fun.
But actually, we have a 500,000 case the yearly for all of the 50 clinics, right?
Right.
But once a time, monthly, so the money complaint.
Yes.
That was survive not so much, but the price, my doctor tell them something, but the price little bit high.
Yeah.
And also sometimes very few case, maybe couple case in the yearly or died. Why?
Right.
Something like that.
Yeah. And sometimes.
But we have a lot of puppy, no problem. That joke, sorry.
Well, fortunately, we do really quite well with sending home a live animal to the client. And our estimates are computer generated. And then when the computer is done itemizing out and giving the total, they'll add 20-30%. So the client now has a range that the bill may come into. So they're not saying, oh, you told me it's
Not like this.
Right, you told me it's going to be $1,000. How come it's $1,250? Yeah, so we give them a range of what to expect. So that helps too. And they have to sign the paper and to indicate that we went over the estimate with them, they understood what the charges were going to be, and this is what we're going to do. And we don't have too many conflicts. If I can't handle it, then I have an office manager come in and do it too.
あとですね、痛み止めの件で、パッチをやるってさっきそれからあと猫ちゃんだとなんかタブになってて飲むのがあるとかなんとかと言ってましたけど、日本ではまだあんまし、ね、痛み止めそんなにやらないけどメトカムとかいろいろありますけども、しかしさっきねお話しした時にその痛みに関してのその動物の感受性ってそう違わないか違うか分かるかって言ったら、これはね飼い主だと。飼い主がそう思えばそうだからというね、その観点もまあ一つあるかなと思ってました。So, I'm talking about pain control after surgery or after something treatment. So, it's kind of like we don't have any exact evidence, right? So, how they feeling, right?
Oh, yeah.
So, but actually with some discussion before, so it depends by the owner to how do you think?
Yeah, in the States, our owners expect pain control. They don't want their animal to be sore. And so they expect us to provide analgesia for them.
Same as Japan now.
Yeah.
And also, you talked about the pain control thing. The cats have a special like, tablet or something?
Yeah, the cats, I don't know the...
Not the Metacam? Metacam has like a liquid.
Yeah, Metacam, well, in the United States, it's different because with the FDA, hard to get approval for use of these drugs in some of the animals.
Oh, yeah.
Yeah, so the FDA licensing process is very long and difficult. So a lot of the drugs that are used for years in Europe or South America or even here in Japan before we have a chance to use them. So we're a little bit slow.
Oh, yeah?
Yeah.
But you can use morphine, right?
Yes.
Can use morphine, but we need to special license. Almost now.
Oh, okay. So
morphine is very good, I know, but very difficult to use because we need very strictly license.
Okay. So it's not that hard for us to get a DEA license in order to dispense and administer the narcotics. We have to renew that license every 2 years. It's not cheap, but with that we can use anything except for Schedule 1 drugs. So.
Like same as a ketamine too? That's why, so I understand. We have a ketamine license, but morphine difficult.
Yeah, and just recently, and I think because of the human abuse of the analgesics, the hydrocodone, Vicodin, those kind of things, seen a lot of humans having problems with addiction to the narcotics. So right now, our requirements that we have to do as far as paperwork for the controlled drugs is so much more than it used to be.
Oh yes,
Yeah.
correct.
So it takes time.
ということでございます。大体皆さんお分かりになったと思います。あえてそういう流れになってますので、まだまだ変化していくと、痛み止めに関してはこういう状況でしょうね。So, thank you very much.
Okay, so let's talk about some surgery real fast. So wounds. We see a lot of wounds. We see a lot of dog bite wounds, cat fight wounds, hit by cars with loss of soft tissue. The thing I try to impress upon the newer doctors at the hospital is don't try to close every wound that comes in. I see more trouble with wounds being closed too early than wounds being closed too late. My basic feeling is that if you give them a chance to heal, they will heal. And I don't have a problem with second intention or secondary wound healing. The delayed primary is when you get a dog in or an animal in with a wound that's relatively clean, but there is some necrotic tissue there. You're going to want to maintain this case with bandaging and some debridement if necessary for maybe a day or so before you go ahead and close the wound. What happens is, especially if you get one in right away that's happened like right then and there, it's awfully hard to determine what's live tissue and what's not live tissue. Of course, you don't want to leave necrotic dead tissue in the system. If you give that wound a little bit of time, the wound will tell you which is not viable, which is still good, and that'll help you with your debridement of it. Secondary closure, especially in dogs and cats, is very viable because once that granulation bed has been established in the wound, they're going to go through a lot of wound contraction. Their skin is very pliable, so you can have a wound that's maybe 4 or 5 centimeters across. Once the granulation bed is established and you give it a little more time, that wound may be only 1 centimeter across. You may not even have to do surgery on it. So let the animal's own body help you out.
これ開放層の場合の治療の仕方ね。
So I just try to impress them upon that. My initial management of a wound is if it's a clean wound, it just happened, and the tissues are healthy. Sure, I'll go ahead and close them at that time. But most of the times, I'm going to bandage them first. If it's a relatively older wound, especially if there's some necrotic debris or some need for debridement, my first bandage is going to be dry gauze against the wound, and then I'll wrap that, cover up that. The reason I use a dry gauze is because that'll stick to the wound, it'll stick to the dead tissue. When you change the bandage and you pull that dry gauze off, you're taking away that dead tissue too. So it's kind of like a micro debridement. Once I'm happy with the quality of the wound, then I'll start using a non-adherent dressing so I'm not traumatizing the wound every time I change the bandage. My favorite wound dressing right now is honey. We use non-pasteurized honey. We get it from New Zealand. We order it on Amazon. It's a Melaleuca honey. And honey is...
Most expensive one.
Yes, the most expensive one. Honey is very good because it increases oxygen utilization by those cells. It's antibacterial, antimicrobial just by itself, and it keeps the wound tissues moist. And I've been very happy with using the honey as a... Yeah, so that's pretty much the only thing I put on the wound. Dropped down to cover? Yep, usually just enough to cover the wound. If I use a non-adherent dressing, unless the wound is really large, then I'll just pour the honey in there. I'll put the non-adherent the honey on my non-adherent dressing and then put that onto the wound and then wrap after that.
Wrapped by what is the material? Wrapped by what?
They're called Telfa pads. Is the brand name. I don't know what it's called. So I put the Telfa pad against the wound. Then I'll put a layer of cotton padding as an absorbent and also a little bit of pressure. After that, I'll put a layer of gauze, rolled gauze, and then my final layer is something like the Coflex, the self-adhering type of bandage material. So it's 3 layers to it.
3 layers. 30にね。
Initially, if it's a nasty wound, the animal will stay in the hospital because we're going to be 2 or 3 times a day changing initially, and then eventually once a day. Once we get back to the stage where they don't need to have the bandage changed every day, I'll send them home, have them come back maybe a couple times a week initially for a bandage change. As it goes further and further and healing progresses, it turns into once a week.
It's same as also cats, right?
Yes.
Cats are lots of biting and injury.
The cat abscesses, for me, provide drainage, antibiotics. They should do fine. I don't use a whole bunch of drains.
Same as a phlegmosis. Phlegmosis like this. The cat there are many cases of the phlegmone of the chicks, bite or infections.
Oh yeah.
Phlegmosis. Same. What drainage first? Usually drainage first.
Abscess. Yeah, I just provide drainage, flush it out. and then put them on some antibiotics. I have the owners do warm compresses to keep the hole open so the pus continues to drain out. Yeah. So I don't use too many drains. I only use drains if I have a very contaminated wound that I'm going to be closing as a delayed primary. If I'm concerned there still might be some excess fluid production, I want to provide access for that fluid to drain and not accumulate at the wound so that the edges of the wound stick together. When I'm doing surgery for like a mass removal, I also tend not to use too many drains. My basic goal is to close up the dead space without the use of drains, if at all possible. Okay, so that goes into mass removals. I will try to diagnose all the masses first before I take them off with a fine needle aspirate. It helps the pathologist with your fine needle aspirates, your preparation of your slide. Recommended to not do a pool smear. What I do is I put the sample on one slide and I press the second slide against it, just a gentle pressure, and I lift it straight up. If I still have a lot of material on there, I use the same slide to make multiple slides, but I don't press it, nor do I and pull it. If you do that, depending on the tissue, but most of the time you're going to be rupturing too many cells. It makes it too hard for the pathologist to identify what it is.
小血のステリーじゃなくてサンプリングしてバイオプシーなんかした時のこの押さえ方ですよね。
Your location of your mass, the type of mass is going to dictate your surgery. Like with soft tissue sarcomas or mast cell tumors, we all know they send out microscopic spread. So the basic goal of surgery is to take a wide margin of normal tissue around it. Be aware of the skin tension lines, which are generally vertically oriented up and down the dog's body. But even with that, the orientation of the mass can dictate too. If I have a dog who's his back here, if I have a mass that kind of looks like that, then your elliptical incision can follow the lines of the tension. If it's like this, which often happens, if I try to orient it along the skin tension lines, my incision is way up here and I'm way out here. So I don't have a problem with going like this along against the tension lines. But what I do try to do in those situations is make sure that my subcutaneous closure is very good, so I don't have to worry about the tension. Along the thorax or the abdominal wall, your cutaneous trunci muscle is very helpful in that too. I always try to include the cutaneous trunci muscle and try to oppose the edges of that I've cut to get the mass out. Borders we touched on a little bit. Mast cell tumor borders, we were told you want to get 3 centimeters around the tissue, both laterally and deep to it. That's somewhat of overkill. Most of the times you don't have 3 centimeters worth of tissue to either side to take off. So I bear in mind that I want to get as wide as I can, but I still want to be able to close the incision. I have sent I always send my mast cell tumors out for analysis. I want to make sure my borders are clean. If I have a result that comes back with a dirty border, my next step is to have the animal back in, and basically I am going to be excising the incision I just made with another elliptical incision. Every time that I've done that, which thankfully, knock on wood, hasn't been too often, and I send that in, the pathologist has never been able to tell me that they see mast cell tumors in the area. So, you know, I don't know what to make of that, and I've also been happy or lucky with the recurrence at the site. Mast cell tumors, I always tell the owner, once your dog develops a mast cell tumor, quite possibly will develop other mast cell tumors around the body, and I have them be vigilant for the arisal of any masses, try to bring the animal in as soon as possible, so that if we do need to do surgery, we can go ahead and do it quickly. Soft tissue sarcomas are nasty. I hate those tumors because they are very prone to recur, and they tend to occur on the limbs, especially distal, where you don't have the availability of a lot of skin to take off. So that's always a concern of mine. Mammary gland tumors, you do always want to send those off. I don't usually recommend fine needle aspirate of mammary gland tumors because just the location of it indicates to me that it's a mammary gland tumor. If I do a fine needle aspirate, the pathologist is going to tell me, yeah, you have a mammary gland tumor, which I already knew, but he's not going to be able to tell me if it's malignant or benign. So no sense doing it if I don't get any information that I don't already know. So we'll go ahead and take those to surgery, and then we'll send those off and determine if it's malignant or benign. If you read, I was taught that the drainage on the mammary tissue is like from gland to gland down the same side. It goes back and forth too. So you don't have to always do a radical to take it off because it may be on the other side anyway. So usually with the mammary gland tumors, if they're small, I do lumpectomies just to mass itself. If it's of any appreciable size, I'll remove that gland. And usually you have to, just because of the surgical technique, you're going to be taking either a gland in front of it or behind it. They tend to be long incisions. Again, I use 2 or 3 subcutaneous layers to close those so it heals well. Oral tumors, I just put that in there just to remind myself. You got the fibrosarcomas, squamous cell carcinomas, and malignant melanomas that typically occur in the mouths of dogs as far as our malignant tumors. Aside from the malignant melanoma, they do not tend to spread to other parts of the body very quickly, and so oftentimes your mandibulectomy or your maxillectomy is appropriate treatment as long as you get good centimeter or so margins. I've been impressed throughout my professional career at how much of the mouth you can take away from dogs and cats, and they still do very well. And so it's kind of scary, but they really handle these things well. Aftercare, basically analgesics, antibiotics if you need them. Some of these surgical sites I'll bandage when I send home and get the client back in about 2 to 3 days to remove the bandage. I don't charge them for that visit, just to make sure that they do come back. And I tend not to charge for my suture removal visits, because I want the animal to come back so I can check them. Gastrointestinal surgery. I would imagine you all are pretty well versed in these types of surgeries. I don't know how much time I need to spend on that. I would like to make a comment on the gastric dilatation involved with this. In a private practice situation, you probably have better survival technique than they do at a teaching hospital, primarily because your clients are there locally. It doesn't take them long to get into the hospital. So time is a real factor. When I was at Cornell...
Like 3 hours, 6 hours?
Yeah. A lot of our clients were shipped there or sent in from, 2 or 3 hour drive away, and that impacts upon your survival rate. When we get them in, we want to identify that it's got gastric dilatation involved with this. It's not a very difficult diagnosis to make. They're typically large breed dogs. We want to get 2 catheters in cephalics, 1 into each cephalic. We want to give them a shot dose of fluid right away. We will try to decompress as soon as possible with a stomach tube. If we can't get a stomach tube into them, we will do a needle centesis, palpate the tympanic area against the body wall of the stomach. Typically it's high up on the right. And I'll stick an 18 gauge needle in there and just hold it until all the gas comes out. Once you decompress some of the gas, after that oftentimes you're able to pass the tube. And so don't give up. When you're passing the tube, you do want to measure the tube from the last rib to the tip of the nose. That's how far you want to put it in. And you want to lube it up very well. If you can't get the tube into the stomach, change the animal's position. Turn them from right lateral to left lateral. Move them around a little bit. I have also been known to blow into the tube to try to dilate the tissue, the esophagus in front of it, so I can pass it in. Once we get them decompressed, you have a little bit of time to better stabilize the animal. But these guys will be taken to surgery usually that night or that day. If they're not in good shape, we might delay the surgery, but most of the time we're taking the surgery as soon as they're stable. And of course, the goal of surgery is to reduce them to normal anatomic positioning, and then to do a gastropexy against the right side of the body wall. My favorite gastropexy technique is the incisional gastropexy. It's quick, it's easy, you don't have to raise large flaps off of the stomach to do certain costs or anything like that. The studies have shown that the incisional gastropexy is more than sufficient to maintain the tight permanent seal so the stomach doesn't flip. I'm a left-handed person, but I'm a right-handed surgeon, so consequently I am standing on the dog's right side on the table. So if this is the operating table, the dog is sitting here with the head over there.
オペして胃粘点直すときにね、まあもちろん右利きと左利きとは違うんだけれども、
Typically the pylorus starts over here on the dog's right side. They will
仰向けに寝たとしてね、
pass ventrally and be end up dorsally on
普
the
通は
left.
逆時計回りになってるもんだから、右側に立ってもらって、ほんでお腹開けて、
Once I make the incision, my first, after diagnosis, you can always tell the stomach is twisted because if you see the stomach and there's momentum lying on the stomach, covering the stomach, then it's twisted. Momentum usually is flowing from the stomach towards cartilage. So once I have made sure that I do have a GDD or a towards stomach, with my right hand, I will slide along the body wall towards the diaphragm, towards the cardia of the stomach, so I can palpate the pylorus, and then with my left hand, I am supporting the body of the stomach in flipping it this way, bringing the pylorus ventrally towards me.
左側の手突っ込んで、それでぐるっと右側に直せば戻るっていう感じで、まあほとんど 80% 左捻転してるんでね。
I've never confronted a twist going the other way. I guess it can't.
彼はほとんどその右側見たことないって、まあ僕もそうだね、まあ右側そういった意味ではないかな。ただ要するにただの胃拡張と似ているっていうケースあるね。
After the stomach is repositioned, I will assess the spleen. In the past, it was always felt that a splenectomy was necessary to be done when you have a gastric patient involved with this. That's no longer the case. The spleen oftentimes is still viable. It's going to look horrible. It's going to be big and swollen, and the chances are you're going to see some hemorrhage at the highest of the spleen. But you can actually palpate those vessels, and you can see if there's adequate arterial supply. Most of the times, the spleen can stay in.
まあ静脈がずっと捻転して閉じちゃってるもんで、脾臓が主題しちゃってるケースほとんどね、そうだね。脾臓も sometimes check out spleen, right?
Sometimes the spleen has to come out if you have a
too much
severe,
big and a dead color.
yeah, if it's not good. But oftentimes, if you assess the spleen and then you're not sure, you put it back in there. You go ahead and do your PECSI, which is going to take some time. Then before you close the surgery, go back, assess the spleen again. Oftentimes, in the length of time it's taking you to do the PECSI, the spleen has improved. So I have never had to take a spleen out at the same time as the gastric.
Oh yeah. Oh,
Okay. Never had to take one out. They all do it.
I had some experience, but after that, take out the spleen, there's so much anemia.
Yes. Yeah.
It's a big look, white.
And the spleen, dogs can do very well without a spleen, but it does. It's a source of hematopoiesis for them, and is involved in the immune system. So if we can leave the spleen out, much rather leave the spleen.
でも日本は結構取ってるね、脾臓取ってますね。やっぱり脾臓の重みで引っ張らされちゃうんじゃないかっていうのもあって結構取ってるケースが多いですけどね。
Just a quick comment about linear foreign bodies. Do you see many of those?
ちなみにあれでしたよね、アニコムさんのアニコムアクションだと異物を飲んじゃうケースの事故が一番多いですよね。
そうですね。
About the insurance things, they are the most high percentage of the foreign body problem
Really?
to pay. no, sorry.
全体で言えば皮膚病が多いんですけれども、皮膚病が全然多いのが多いんですけれども、胃ですとか胃腸に関してはかなり。
About the open surgery for the stomach and the digestive things, so the foreign body is the most worst number.
だったような気がします。
Yeah, I read the news actually from their information.
So the linear foreign bodies can be quite scary because of the need to make multiple enterotomies to remove the foreign material. I just had a dog in, a husky, a 12-year-old husky. She got the owner's dental floss. She chewed up the dental floss container, and that got hung up in her stomach. And the dental, they went all the way down. The entire small intestine was involved into the colon. So that was does a kind of a dicey surgery. Of course, the mesenteric borders where you're going to have your
がんが向きを変えちゃって胃から腸の方に行くとね詰まっちゃうね向きを変えちゃうとね
But there's and I've never tried it, but there's a technique I'd like to try where you relieve the proximal obstruction, you leave yourself enough of whatever foreign material it is that's going all the way through, you tie that to a
なんかアリゲーターフォーセ
a
ット
catheter, yeah.
アリゲーターフォーセット
No, you tie it to a catheter, a red rubber feeding tube.
カテータ
Catheter.
カテータいやいやいや
Yeah. So you tie that, whatever it is, to the catheter, and then you put that in, and you can milk
おう
the catheter down through
Milk?
the loops of bowel into the colon. So maybe you don't need to make all those enterotomies.
Oh, yeah?
Yeah, I didn't want to try it on this one because it was the entire length of bowel, and I wasn't sure how.
Because it's automatically the bowel started to a normal movement. That's why.
Yeah. Well, no. Once you when you do your.
But how to guide it?
Yeah, when you do your foreign body, typically it's in the stomach
Yeah.
or in the base of the tongue. So you always want to check the base of the tongue. Once you relieve that proximal obstruction, you can actually you're told to hold on to that, right? But if you let that go, it'll go down, and a certain portion of the gut will lose the plication. So the idea behind this is it gives you something you can actually feel inside the intestine that you milk down. Extruding without
Milk is like a kitty milk or puppy milk, something like
No,
that.
when I say milk, I mean with my hands. I'm going to be milking it down.
Oh,
so-
milk it down like
Yeah.
this, push it.
Yeah, push it down. Yeah,
Catheter.
the catheter that you have attached to the foreign material.
Yes.
So in that way, you're
2.44
a
two-
big catheter, like a
Big, right?
12 gauge, 14 gauge
I
catheter.
understand, okay.
Yeah.
Like a poly
Not a poly, but red rubber feeding tube. Yeah, something big that you can feel. So that way you may not have to make all those enterotomies.
ちょっと弾力性のあるカテーテルの14ゲージぐらいのやつだったら丁寧に入れてってこの咽頭反射があるようだったらそのままこうやって入れていけば胃を通ってずっと腸で最
Because
後
once you get
変なアナ
that,
ルまでいっちゃう
once you get that into the colon, you're done. Your assistant can
yeah.
pull it out. So, but I didn't want to try it on this one because it was the entire small intestine. I just wasn't sure about that technique. But if I have one that's a little bit shorter length, I'll try that and see how it works. Because it'd be nice to be able to do it without.
まあ短いのだったらね。So how do you think maximum how much size you can use for doggy cat?
Well, in this dog that I did with the dental floss, I had my gastrotomy, and then I had 6 enterotomies after that.
6.
6 enterotomies, 6 separate incisions into the small intestine to relieve the obstruction.
Okay.
Yeah.
So any dog basically,
Yeah.
any breed.
Yep, And of course, after anytime you open up the gut, you're gonna no food or water for at least 12 hours. But you do want to try to get them back to eating and drinking as soon as possible. Okay. And your antiemetics, including Serenia, are good to use too. Serenia also is a decent visceral analgesic too, so the belly doesn't feel quite so bad. And Serenia for us is Maropatent, is the name of the drug. I don't know if it's the same name here for you guys. Okay, liver, gallbladder. Not too much you're going to be doing with the liver. Either you're going to be removing a lobe or part of a lobe. My preferred liver biopsy technique now is with a 6mm biopsy punch. Do you guys use those, the biopsy punches for the liver? So the skin
バイオプシーのこれカチッてやってこうやってつまむやつ肝臓栓死やる No, I don't think so.
Okay, so you know what the liver biopsy, the skin biopsy punches are? With the round blade?
Yeah, skin is easy.
Put on the skin and you twist
But the
it.
liver is a bit scared.
Yeah, so with the liver, you can do the same thing. With a 6mm punch, you put it against the surface of the liver, twist it gently till it goes in, pull your punch out, grab gently the liver sample with your forceps, pull it up gently, and just cut it off at the base.
It's
And that should-
open or end of kind
Open,
of
open.
open. Oh, okay.
Open.
オープンした時ね。
Yeah, if you, of course, you can do endoscopy or
ああ、その
laparoscopy.
時にね。
So once you get that out, of course, it's going to bleed up out to that hole. Gel foam is very effective. You cut a little piece of gel foam, plug the hole with that,
うん。
and usually by the time you're done with the surgery, it's no longer bleeding.
うんうん。
So my other preferred technique for liver biopsy is with the guillotine method, using, as it's described in the books, you find an adequate projection of the liver, you encircle it with, I like to use gut for that. Slowly tighten your ligature so it compresses and cuts a little bit, and then you cut your sample off, leave a cup of liver tissue to prevent that ligature from slipping off. But you can get good sized samples with that. You can also take samples along the edge. It doesn't lend itself to the guillotine technique with just take a wedge of tissue and gently close with capsular sutures of the liver. But
How much of the cost usually asking the client? This kind of a liver biopsy things. Plus how much additional? Couple $100?
If we just going in to take liver biopsy and that's all we're doing, I think that surgery itself is about $200. But you have to add on to that the cost of the biopsy itself, the anesthesia, and everything else. At our hospital, surgeries tend to be close to $1,000 no matter what. Gallbladder surgery, not as common and it's not as much fun as other surgeries because bile is such an irritating substance in the gut. It's going to range from dogs with bile sludge where you want to make a colotomy and you're going to flush it out, canalize the bile duct to make sure it's patent, and then close it up. You want to use an inverting pattern when you close the gallbladder. Cholecystectomy, you need to make a small incision in the serosa where the gallbladder attaches to the liver. Once you make that initial incision, just with some gentle pressure on the gallbladder and blunt dissection techniques with your scissors, you can take it out of the hepatic fossa where it lives, and then you're going to want to get down to the cystic duct. There is an artery that's associated with it that you're going to have to ligate. When you do these, if you're going to, once you get the gallbladder mobilized and you got your ligature on it, you want to use a non-absorbable suture material for that ligature. If you use an absorbable suture material, as that suture material dissolves, it may no longer hold the duct closed, and then you're going to get a bioperitoneum. So that's one of the situations where you're going to want to use a non-absorbable suture material when you ligate that cystic duct. Biliary rerouting, I don't have to do that quite so often. The most common indication for that was those dogs with chronic pancreatitis, where they would develop a huge huge fibrotic mass of the pancreas at the angle of the duodenum, such that it would block the drainage of bile from the liver through the common bile duct. For those, we would mobilize a loop of the jejunum, bring it up to the gallbladder. You might have to release the gallbladder from its fossa in order to take the tension off of that incision, and you're going to want to do seroso to seroso closure first at one aspect of it. Make your holes into the gallbladder and the intestine. Then you close mucosa to mucosa, both sides, and then your last one is again seroso to seroso. So it's 2-layer closure both ways around the side. I don't know if you
It's talking about the gallbladder approach, right?
Aftercare again is they typically are sick animals, so they're probably going to be in the hospital for a while. If you've done the biliary rerouting, then you're going to want to hold that animal off of food for a good 12 to 24 hours.
We are actually very concerned that these cases are lots of emergency case for the gallbladder. It's a very delicate, weak.
Yes, it's
Sometimes,
it's not fun to work with.
yeah.
So you got to be real careful. Very gentle technique is necessary. That would be one instance where I'd use a taper point needle versus any type of cutting needle.
Like a 4-0 tapers.
Yeah.
It's usually chromic, right?
No, I don't use chromic. It's gonna go away too soon. So that would be a
Cut.
PDS.
Or PDS.
You can use absorbables for the gallbladder closures, because that should heal very well. It's just for the ligature of the cystic duct. When you're doing cholecystectomy, you want to use a non-absorbable.
PDS may be a couple of months after absorbing. How long take absorbing?
PDS is going to take a good,
Maybe a couple of months.
to go completely away, it's going to take a good 9-10 months.
9, 10 months.
Yeah, to go away.
Long time.
But the strength of it is maintained pretty well for about 40 weeks, 42 days or so.
And no reaction. Yeah,
Right. No reaction.
yeah, that's the best answer.
Real quick, splenic surgery, the blood supply is mainly from the celiac artery, and other branches off that artery are going to provide blood supply to your pancreas and also to a portion of the greater curvature of the stomach, including the short gastric arteries. Don't worry about the short gastric arteries. You can take those away. The stomach is still going to survive. Do be aware of the branch that goes off to the pancreas. It's usually pretty deep in there, and it's usually not even in your field. But
まあ糸の関係ね。糸の関係で大丈夫だったらっていう。
But with the spleen, it's basically an exercise in ligatures. Typically, you'll have some momental adhesions to the spleen. What I basically do is with my fingers, I just make pedicles, vascular pedicles, either of the momentum or the splenic mesentery that's there. And I put my clamps on, transect the clamps, ligate as I go, and eventually take it out. You can, in a small dog, you can do this.
まあ、非的のプロセスですね、今言った。
And as few as 3 ligatures. It doesn't take that long. You do want to separate the splenic artery from the splenic vein and not ligate those together. The concern is that maybe you get an arteriovenous fistula that occurs as that heals. So do separate the vein and the artery. Pancreatic surgery I'm not going to do a whole bunch with because it's not an organ that we really have to do a lot of surgery on. We was told in school, don't touch the pancreas, it's the worst thing you can do. Well, that's not exactly true. You can touch the pancreas. Sometimes you can.
膵臓ね、絶対触っちゃいけないって結構注意ね、言うじゃない。ね、柴田先生。結構さ、怖がって僕らもね、そんなことないよって。結構触って。
But actually the surgery on the pancreas is relatively easy in that you make a small incision in the mesentery over the pancreas. If you're doing a biopsy, it's very simple to bluntly dissect with a hemostat to separate a lobule, and you can just pick it out, and oftentimes it doesn't even bleed. A little bit more of a problem if you're having to do duodenal surgery because the left and right pancreatic duodenal vessels anastomose within the pancreas in that area, and that is also your vascular supply to your duodenum. So you got to be very careful when you're doing that, and you have either pancreatic surgery or biliary or duodenal surgery to not mess up the blood supply to either of the organs. So your fine dissection, careful dissection is very important. Aftercare, you want to get the bleeding as soon as the vomiting is under control. We do a lot of urogenital surgery, bladder stones, blocked cats. I put the ovarohysterectomy and ovarectomy on here too. In the States, we're doing ovarohysterectomies. In Europe, they do ovarectomies. They think they have the better procedure. I think in the States, we think we have the better procedure. I think they're both good. The concern with the ovarectomy by itself is that you would leave the uterus inside, maybe an increased incidence of uterine cancers and things like that. But uterine cancer is not very common in dogs, and most of these times you're dealing with puppies where they have a very small uterus, and it doesn't cause them any problems. Castration, we're all pretty good at that. Renal surgery, usually it's going to be a biopsy, although if you biopsy the kidney, you got to be very careful that your other kidney is working, because even taking a biopsy from the kidney can shut down its function. Nephrectomies are a little bit harder, and the bad thing about the kidneys is that the blood supply, especially the arterial supply, is very variable from dog to dog. So you just be very careful when you're dissecting. You want to make an incision in the mesentery or in the peritoneum, because the kidney is in a retroperitoneal location. So in order to gain access to the vessels, you have to be in that same spot. You make an incision in the peritoneum. You reflect the kidney so that you can do your further dissection along the dorsal aspect of the kidney, and that's where your vessels are going to come in. Ureterotomy, I've done a few of them, mainly for stone removal. You're going to use very small suture material, 6, 7, 8 aught, an absorbable suture. You want to be very careful with that you're not going to cause stricture. So accurate placement of your sutures is very important. Don't worry too much about it because it's not often that we need to do that. Cystotomy, we do a ton of cystotomies. I'm sure you guys do a lot of cystotomies too, mainly for stone removal. Retropulsion is a very good way to get the stones back into the bladder so you don't have to do a urethrotomy. The bladder is just like the stomach in that it's a very forgiving organ. You don't really need to be a real good surgeon to be a good bladder surgeon. I tend to use a double layer closure. I will close my mucosa first, and I'll do a serosal submucosal oversew with inverting pattern, and continuous closure is very fine for the bladder. It really handles surgery well. Urethrotomies and urethrostomys. Urethratomies mainly in dogs because their stones lodge at the os penis, and even with the retropulsion you may not be able to mobilize that. So you're going to make an incision right over the palpable stone and take it out. I tend to leave my urethrotomies open to heal by second intention. Less chance of strictures that way, although the downside is that it's quite messy and the animals tend to bleed a lot from the site for at least a few days after surgery. So we tend to keep those animals in the hospital for a little longer. Your urethrostomy in any animal is the success of your technique is going to be dictated by your apposition of the mucosa with the skin. That should be accurate as close as possible so that you don't get scarring. Cats for perineal urethrostomies, the biggest problem I've seen that requires reoperation is either poor dissection and not releasing the ischiocavernous muscles from the pelvis, and also not dissecting farther enough dorsally so that the bulbourethral glands are not able to flow. You get it to the level of the bulbourethral glands, you're going to have a large enough os for the animal to urinate through. Vulvoplasties. The reason I put that up there is every vulvoplasty I've done seems to be a lot more painful than I would expect it to be. So pain control is very important for those female dogs who have to have a vulvoplasty. Are we doing okay, Dr. Honma? Am I going too fast? I don't want to.
No, that's okay. Yes, maybe another one more page, 18th. Give us a chance to question.
Okay. Hernia repair.
Yeah.
We talked a little bit about that. Dr. Honma was mentioning that for a lot of your umbilical hernias here, you're using a mesh to replace
or to
close it. I haven't had to do that.
ペニアactually.
Oh, for
AL にはメッシュを使ってるでしょ。ね。ほとんど使わないっていうから。Okay.
On the body wall, your layer of strength is a rectus fascia, the very thick outer covering of the muscles there. What I do with my
まあ本来であれば何重にも筋肉が構成されてるもんだから。
Oh, with the inguinal hernias, you're doing the mesh, yeah. Okay. Umbilical hernias, I just fix those at the time of stay. They typically are not big enough to cause much of a problem for a dog, and most of those don't even need to be fixed. Inguinal hernia, again, is adequate placement of your sutures, and also making sure you incorporate the rectus fascia in those sutures. That's going to be your layer of strength. For the traumatic body wall hernias and the inguinal hernias, and sometimes for the diaphragmatic, but also for the peritoneal, it helps you to pre-place your sutures before you tie them. So I will pre-place the sutures, I will tag them with a forceps, and then once I have all my sutures placed, then I'll tie them to close the hole. The reason for that is if you placing your sutures and tying them as you go. When you get to the last part of the hernia that needs to be closed, you can't see it anymore because you closed most of it. It's hard to identify the edges, and that's the important thing.
Also PDS use.
Well, no, I'm using all non-absorbable grafts for those. Yep, I want that suture to stay forever.
What? Sorry.
I'm using non-absorbable sutures.
Non-absorbable is
Nylon.
actually like a nylon?
Nylon. Nylon. Yeah.
With taper?
No, usually cutting because it's pretty tough tissue that you have to get through. Yeah, usually a cutting needle. The perineal hernias, I've had the most success when I've used the obturator flap transposition in correcting those. So the anatomy is oftentimes very distorted. You oftentimes have a lot of periprostatic tissue in the area, which makes everything hard to identify. Once you're able to either excise that periprostatic tissue or get it reduced back into the belly, then what you want to look for is the levator ani and coccygeus muscles arising from the base of the tail. They kind of start medially and progress laterally. The wall of the rectum is going to be right there, and then on the floor of the pelvis is your obturator muscle. So you can, after you get everything cleaned up and you're ready to suture, with a periosteal elevator, make a small incision in the origin or the attachment of the obturator muscle on the floor of the pelvis, and then with your periosteal elevator you can mobilize that flap such that you incorporate that into your sutures when you repair. I do also take a small bite of the sacrotuberous ligament as another anchor point for that. Since I've been doing the obturator flap technique, again, knock on wood, I've been very happy with the results and no recurrences. The one demand I have of the client in this case is that all these dogs that I've had have been intact male dogs, usually older. I require that they castrate the dog at the same time because the recurrence rate is quite high if you don't castrate at the same time, and most likely because of the effect of testosterone on the muscle integrity of the pelvis. Traumatic body wall hernias, I counsel you to, if the animal is stable and can be managed with some bandaging so guts are not hanging out, I would recommend that you give those a couple of days before you take them to surgery. Give them a couple of days, allows the tissues to calm down, and you're able to identify the edges much easier so that you can close it well enough. So I know I kind of blew through these very fast. I'm sorry.
そうすごい内容だけどさ、大体こう臨床家である程度っていうか、経験してるドクターからざっとよくやってくれってこういう話になってたんですけど、いずれにしても今ヘルニアの件だとかその前にちょっとあれでしたよね、遠尿道路切開術だとか膀胱切開とか我々結構やってるのが出てきましたね。それでどうですか質問。ありがとうございます。
Don't force him to ask questions. Don't force him.
OK。ね、どう柴田先生、質問。僕なんか例えば最近ついで just 3 days ago I heard the operation for the inguinal hernia やってるでしょ。ね、メッシュ。
左メッシュ。多分けどちょっと落ち着いてないみたい。
そうだけど彼はさほとんど縫い込みでやるっつってる。
筋肉がもうほとんどなくてもペラペラでも基本的にはそのまま縫います。
So even that was very small toy size dog and sometimes old, right? So very weak and very thin. Usually like sutures, but it's easy to peel out again. So and also very close to the another side, and also one side, both side, like round, all round, 360 degrees. It's too much, but like almost like this.
So you use a mesh for that one? I can understand that. Most of the inguinal hernias are due on the puppies when it's been identified
Puppy.
very early.
But puppy like this, right?
Yeah.
But we like here.
Oh, that's perineal hernia.
Yeah, it
Yeah, that's called inguinal hernia.
perineum.
Yeah.
Mm-hmm.
So I haven't had to use the mesh.
Yeah, sorry, it's perineum.
Yeah.
Yes.
I've been happy with the obturator flap technique. And
Also,
have
あれだって筋肉のフラップ。
have you used that? Have you tried that one?
いやいや、僕やったよね、よくね。筋肉のフラップでさ、恥骨筋とかさ、持ってきてこういうふうにして、いやいや、but it's not enough and very difficult to push it in. Because all the time
It's hard to get that stuff to
Yeah.
stay in,
yeah.
So what I do is I use my Alice tissue forceps. I get a gauze sponge, I moisten it, I fold it up, and I put that at the end of the Alice tissue forceps, and then I use that. After I get everything in there, I use that to plug the hole during the time I'm pre-placing my sutures.
アリス監視でさ、うまくつまんでてグッと押し込んで、要は監視の穴だけ、監視のサイズだけの穴になるんじゃない、グッと。で、その時にギュギュギュギュってこう縫い込んで締める。You do it.
それが
難しいね。そうわかる。
縛るともうちぎれちゃうようなもう
そう
重い組織しかなくて。
Yeah, because with so much tiny teeny dogs.
Yeah, it's harder with small dogs. Yeah.
Yes.
I agree.
犬はね立派なコーギーなんですけど、とにかく筋肉が薄くなっちゃって。
何もないでしょ、ケツのところも骨がもう出っ張っちゃってさ、ケツのところのね、恥骨がね。そうわかるよ。So, we maybe next our homework.
Okay. These are the references I use for most of them. Small Animal Wound Management, which is this book. That's an old book, but he's got a lot of information about wound healing in that one.
Oh.
And those are all written in your notes, so you don't have to write these down. Small Animal Surgery is a new, second edition is now out by Dr. Fossum out of Texas. I'm sorry, this is sideways, but this is the fourth edition. Very good book. It has a lot of procedures in there, and it doesn't get real in-depth into a lot of the pathophysiology. Good diagrams. It's an excellent book. If you were going to become a surgical specialist and sit for the boards, you would probably read Slatter's end to end. That's information ad nauseum about small animal surgery. It gets into a lot of the pathophysiology of the disease. But those are the three for small animal soft tissue surgery. I think you can get by with just having these three in your hospital. Okay. Orthopedic surgery, a little bit different, right? Yeah, so your knowledge of anatomy is going to be a bit more crucial, because you're going to be all over the place versus just in the belly where it's, you know, it's complicated, but you in and out so many times things are familiar for you. Your instrumentation is going to be a little bit more rugged. Bone holding forceps, they're nasty looking instruments. Homon retractors are very useful for evaluating the meniscus during cruciate surgery. And then you got your pins, your K-wires, power drill, plates, and external skeletal fixation set. I did not put the femoral nails on here. I have not used those yet, but the femoral nails are also being used now too. Do you guys know what the nails are versus the pins? So basically, you do?
Yeah, usually we use the pins is more than the 10-pound dogs. The small dogs we more than the plate. Flexible plate.
Well, the nail. The nail is it's an IM pin. And the problem with IM pins, they're very good at resisting bending forces. The pin. But they're not good with rotational forces. The pin by themselves. So the femoral nails, so if this is the shaft of your bone, if you had a pin down the middle of that, if that's your IM pin, biomechanically that's the best stabilization against bending because it's at the center of your cylinder. But the bone can still twist around that pin, right? So the femoral nails are special IM pins with holes at the top and the bottom, so that you place the pin and they have a special jig that you attach to it. You actually put the screw through the holes. Usually just a couple holes top and bottom. Your fracture is here, and because you're now attaching the pin to the substance of the bone and the pin, that provides you
screw to the pinhole.
through the hole in the pin. Yes, the pins have pre-placed holes, so that and with that special jig, you can find those holes, get the screw through it, and that provides your rotational stability. So, but I haven't had the opportunity to use those, so I didn't put that in there. But I know a lot of surgeons are using those now.
Oh, this is not popular in Japan.
Yeah, this is.
What is the name of the pin?
They call them nails.
Nail. N-E-I-L.
N-A-I-L. Yeah, femoral nail, tibial nail.
Nail pin.
Yeah.
Maybe tell me more exactly later.
Yeah. I don't have them, so I don't know either.
Thank you.
Okay, so this is an example. This is my ASIF elevator, cutting surface right there. And my favorite instrument, pretty much overall, is this little guy, the Freer elevator. So it's a double-ended instrument. We put a marking tape on the side that's been sharpened. And I like it, again, because of a lot of the small dogs we deal with. It's got a very small cutting surface.
Yeah.
It's very safe. This side is left blunt and used as a probe or a retractor. It's the size of a pencil, so it's very easy to use. It's called a Freer elevator. Yeah. With your elevators and you're approaching to the bones for fracture repair, it's important that you stay underneath the periosteum, subperiosteal elevation. That way you'll be much less liable to damage any nerves or vessels that supply the muscles in that area. Oops, wrong one. These are sharp retractors, little finger retractors. Most of my fracture repairs, I have an assistant with me. So they will use these to retract muscles for me. This is a rongeur, a double action rongeur for removing bone. These are my next favorite orthopedic instrument. These are Staghorn bone reduction forceps. These work very well for those small dogs. They also work very well for interfragmentary compression and reduction while you're putting in your more permanent stabilization. These are called speed locks. They're like a Staghorn, but instead of a box lock, you have this little screw that you can tighten and again holds. These are a bit bigger than the speed locks. They're more applicable to the large breed dogs. Probably the workhorse of your orthopedic surgery is, for me at least, is the Kern bone holding forceps. These are the small ones. We also have large ones too. They got very nice gripping surface there, very easy to use. These are, they look like needle drivers, but those are my wire twisters. They are, the head of this is a lot bulkier than your needle driver, and those I use to twist my cerclage wires. Very important when you're using either full or hemi-cerclage wires is your twisting technique. You want to place your wire and with the hand put your first couple of twists in so that the wires twist around each other, and then attach your whatever instrument you're going to use to twist those wires to it. Pull away from the bone at the same time you're twisting. That'll allow those wires to continue to wrap around each other instead of one wire being straight and the other wire wrapping around. That's not going to be stable. So these I find are very easy to use to achieve that. Again, you pull against it as you twist it. This is my pin pack with a hand chuck and key. This is my Hall trauma drill. So for my power placement, my drilling, and my screw placement. This thing, I got this in 1991. It's really old, but it still works very well.
Made in Makino? No? Made in Japan, Makino? No?
No, Hall is a U.S. company.
Yes, we come.
And it runs off compressed nitrogen. Nowadays, I don't think anybody uses this kind of stuff. Most of the surgeons now have power tools with a battery is attached to it. Yeah. And this is my plate set. This is for my 2.7, 3.5, 4.5, and 6.0 screws. When I had my technician take the picture, I forgot to tell her to take this out so you can see all the instruments associated with the plate set. So I have a plate set for 2.0 and 1.0 applications for the small dogs. I have this one for the medium to large breed size. I also have the capability with another pack of using stronger ones, is 4.5 and 6.0, 6.5 millimeter screws. So I have 3 different plate sets depending on the size of the dog. They all will have the drill bits, the taps, and the length, the gauges, the length gauges. This is my external fixator pack. I don't use external skeletal fixation very much, but there are cases that just cry out for the use of an external skeletal fixation versus other types of repair. The instances where I use this most is when I have an open fracture that I want to maintain access to the wound, or if I have a highly common unique fracture that I don't think I'm going to be able to rebuild the cylinder of the bone, which is important with plates and screws and pins and wires. I'll use this as what's called appositional orthopedics. So basically not even making an approach to the fracture site so that I don't screw up the blood supply to those fragments. I just visualize the length of the leg that's necessary, place at 90-degree angles at the top of the bone, at the bottom of the bone, place my connecting bar for those two, making sure I have the alignment correct, and then a couple other bars, either a full pin or a half pin configuration in order to maintain the stability. So as the body heals, they'll incorporate all those little fragments that I have not traumatized by removing them and taking away the blood supply. And that's actually one of the bigger advances nowadays in orthopedic surgery, or at least fracture repair, is to not expose the fracture as much as we used to.
Yes. Now it's getting popular in Japan.
The external fixers?
Because we have so much tiny dog, right? So then totally no bone marrow space. So then even little bit like this, but it's better than miss.
Right.
Yeah, that's why.
I have an example later on with not using the external fixer, but of how well things can heal without even putting the bones back together. And this is a close-up of the clamps. Patella luxation, I would imagine with your high number of toy poodles here, you see a lot of patella luxations. Yeah. I don't see very many lateral luxations. The vast majority are medials, grading from 1 to 4, depending on the length of time the patella stays in the groove. Most of my grade 1s, as long as we watch them and carefully monitor them, quite a few of those will not need to have surgery. Radiographs are important as your pre-surgical planning. Let's see. So what I do, I'm sorry, it's not a very good room for this, but after diagnosis, I schedule them for a day in the hospital where I give them a sedation, and I take x-rays of the limbs. This is it's not an AP view, it's a PA view. So this animal is lying on his belly, his external recumbency, and that leg is pulled back like this. X-ray beam is coming this way. That way, it gives you a much better idea if there's any significant femoral or tibial torsion. This particular dog, he was a grade 2 patella luxation, starting to become clinical, showing more lameness. You can see his patella right there. Tibial attachment sites right here. When I took this guy to surgery, I was thinking I was going to have to do a tibial crest transposition, but his problem actually was he had no groove at all. There was no trochlear groove. So just a trocheoplasty for him was sufficient to keep the patellar reduction. They all get a trochleoplasty no matter what. Some of them may need a tibial crest transposition. They also get imbrication of the lateral joint capsule and also the lateral retinaculum. I do have the lateral view. You can see on this one, he also has a cruciate tear. And you can see that by the relative displacement of the tibia cranial to the femur. So he also had a cruciate tear that was repaired at the same time. Okay, that brings us to cruciate repairs. So this is probably the most controversial orthopedic technique that's out there right now, only in the sense that we see so many of them, we don't have a good idea why it happens in these dogs without any traumatic incidents. And so that's led to the development of the newer tibial osteotomy techniques. Do you see many of those here?
Oh yeah, because the racing dog and the hunting dog also.
Okay.
And
And
but the patella is more than this, but
Yeah,
this
yeah.
one also we see.
The diagnosis is not typically very difficult. Usually you'll get the drawer sign. I recommend that you try to demonstrate the drawer sign on the dog when he's standing. Try not to lay him down for that. If you lay him down, they kind of get tense. There might be too much muscle. You can't get the drawer sign well, so I will always try to do it with him standing. The palpation, your landmarks for doing the drawer sign is whichever hand is above or below is one finger on the patella, your thumb on just behind the femoral condyle on that side, just by where the fibula would be, your other finger on the tibial crest, and caudal head of the tibia. When I have the students out, most of them can't demonstrate a drawer sign, even though they're certainly strong enough to do it. But I think their problem is that they're grabbing it too hard. You don't really need to grab it very hard.
They're feeling so much gap.
Well, what they're doing is they grab it, they can't do that when they're grabbing it so hard. And they're also, versus doing the drawer sign, they're flexing and extending. So,
大腿骨頭と頸骨、腓骨の頭のところに両方ともこうやって指やってこうやってこう押さえてみて、ここで足の握りがどう強くこうやれるかとか、その時のこの滑り、ちょっとこう要は大腿骨の遠位端と頸骨、腓骨の近位端のところをこうやって切って押さえてこう見ると十字靭帯のところのズレが非常にこうルーズになっているのが分かりやすいっていう。
The cruciate's functions in the joint are to prevent hyperextension and excess internal rotation, and to prevent the drawer sign, the translational motion. There's two parts of the cruciate: anterolateral band and craniomedial band. The one that's most often torn is the cranial band, and with that, what you'll see is you may get a drawer sign in flexion, but you might not have a drawer sign in extension. It's somewhat of a moot point because even with a partial tear, typically the dog is going to go to surgery. So if you have any type of drawer sign, you're typically going to take them to surgery. The other thing that's very typical for them is during the initial palpation is you have what's called a medial buttress, which is a thickening and a hardening of the periarticular tissues, especially on the medial side. If you have a dog with only a unilateral tear, it's very easy to feel that compared to the other knee. The tibial compression test is also something that can be done. I'm not as comfortable with using that as the sole mean of diagnosis because even with the cruciate tear, you can't always demonstrate that. Radiographs are typically taken not so much to diagnose the problem, but to get an idea of how much degenerative changes you might encounter in there when you're doing the surgery. Let the client get some idea how much arthritis is in there. And also to rule out other things, including cancer that could be mimicking the signs. Usually the only finding you'll see with a cruciate tear radiographically, where is the displacement of the fat pad cranially. And so you can't really see it here because they're lighting. But the fat pad, often in a normal joint, you're not going to be able to see. If you have an effusion in the joint, that's going to push the fat pad cranially, and then it'll be radiographically apparent. Surgery, I do extracapsular repair. The other option that's in vogue now is one of two tibial osteotomy techniques. Either your tibial plateau leveling osteotomy or your tibial crest, tibial tuberosity advancement. The premise behind both of those is not so much to take away the drawer sign, but to neutralize the forces during weight bearing so that when the animal is placing weight on the leg, there is no, the forces are equalized so you don't get the translational motion. After these surgeries, you can still demonstrate the drawer sign. When they first came out, they were supposed to be the next best thing to sliced bread in that the animals can go back to full 100% athletic recovery, and then long-term stability was much better than the extracapsular repair. As time has gone on and these surgeries have been done and have been evaluated, it's not proving to be the case, and nobody can tell us right now if either of those, assuming they're both well done, is better than the other. So I'm still doing the extracapsular repair, and I use the Securo system, which is a system using 80-pound test nylon and 3 metal crimps to hold the suture in place. Surgery, you always check the meniscus. It's oftentimes you have meniscal damage at the same time as your cruciate is torn, or over time with the instability. It's typically the medial meniscus, and that's where the Holman retractor, which is this little guy, comes in. This is for the small dog. The blade side is very small. It's not a blade, small blade, because it's a wide area. You're going to hook this hook on the back side of the tibia, and then you use that to lever the tibia forward, so you can get a good look at the meniscus.
This is for only this like tibial approach only. Use this.
This is through a parapatellar approach.
Yeah.
Yeah.
Through to the tip to the capsule to put.
Yeah, this goes right into the joint. You're going to put it right where the cruciate ligament was. You're going to gently put that back so the hook engages.
It's a kind of guide, right? Guide.
It's used as a lever in this case, so that it really pushes the tibial plateau forward, so it gives you a better look at the menisci.
You through to the suture, this one?
No.
Nylon suture through to this, like this?
No,
No?
no.
Oh, okay.
Just the knee is there, it's open. I put that right past the trochlear groove and try to engage this at the back part of the tibia, and then I lever that so that it brings the tibial plateau closer to me, so that I can see the meniscus.
Oh, okay.
Yeah, so it helps to visualize the meniscus, this instrument. Usually if I have to remove a portion of meniscus, I'll have my anesthetist, the technician who's washing anesthesia, put on a pair of gloves to hold the elevator and the knee, so that I have both hands available to get the meniscus out.
十字靭帯征服したりいわゆる脛骨のねところからアプローチするにあたって僕あんまりそういうの縫い込むだけで正式にその縫い込めば結構もっと戻るもんだから、これはその要するに正式に征服する時の道具だね。
Osteophytes, especially if it's a chronic, you'll see a lot of osteophytes, which is an indication of the degree of degenerative changes. I don't worry about those. The only time I remove osteophytes is if they're occurring at the entrance to the trochlear groove on the femur. Most of the times you won't find them there. There'll be a line of osteophytes just lateral to your trochlear ridges. I don't take those away. It doesn't really make a difference, and it just causes more bleeding in the joints. And then I always imbricate the retinaculum. The retinaculum is an extension of the tensor fascia lata that encases the thigh muscles, and that is a continuous sheet that goes all the way down the limb and acts as a sleeve for the muscles. You identify that as you can incise just in front of the edge of the vastus lateralis muscle, and you can follow that all the way up to divide the muscles. That's very thick, very strong tissue. When I'm done with the stabilization of the joint, I will trim a little bit of that off and suture the ends together so that I have a little bit more tightening on the lateral aspect. Aftercare, these dogs definitely get iced. I send home instructions for the owners to continue icing the area 4 times a day for at least 3 days. 6 to 8 weeks of strict confinement, no running, no jumping, no stairs. They need to be on a leash. They go outside to do their business. After that 2-month period, then we start to, depending on how the dog's doing, we start to increase the exercise as far as taking out for longer walks. Quite a few of the dogs are doing sufficiently well before that 2-month period that I'll let them start to go swimming as part of their physical rehabilitation. But I tell these people after this surgery, 4, 5, 6 months down the road, we're still not going to be allowing your dog to run around.
Usually, how many days are in hospitalization?
They stay overnight. Go home the next day. Yeah. I'm just in general, I'm a firm believer in getting them out of the hospital as soon as possible. As long as they are stable, get them out of the hospital. They're happier at home. The parents probably provide better TLC or more TLC than we do at the hospital, and it's a much less stressful situation for them.
Oh, yeah, correct.
Yeah. A lot of times I have an animal in, and for whatever reason, if they have to stay a couple of times, they won't eat at all in the hospital, no matter what we feed them. And we send them home, first thing they do is eat. So
Much more better.
yeah, I'm very, very much into getting them home as soon as possible. So yeah, these guys just stay overnight. Go home the next day. My fractures, most of my fractures, in fact all of them, go home the next day. I don't keep them in the hospital. They do much better.
In this point, very different compared to Japan veterinarians. So now it's becoming closer because becoming similar because we have small dogs, they can take care. But over this much size dog is in Japan. Maybe owner doesn't have confidence because a lot of people working both of the
Yeah.
yeah.
They're not home to watch the animal.
Yeah. And also basically even small dog is free in the house, not in the so much good for like a cage. Yeah, like a crate control is difficult.
Hard to do, yeah. Yeah, I can see that.
Yeah.
That is tough for people. So usually when I have the initial appointment with these people, I tell them this is what you need to do for 2 months afterwards. And that gives them time even before the surgery's been scheduled to figure out how they're going to do it. For the small dogs, I tell them playpen is perfect. A child's playpen. You know, it's like 4 foot square. If you need to, you can put a piece of plyboard on top so the dog doesn't run out, but it's a good size enclosure for the small dogs. And if it's a big dog, I recommend they keep the dog inside at least temporarily. Maybe use the laundry room or utility room as the confinement area, the bathroom. Whenever they do that, I make sure they put down some type of carpet or something on the floor so it's not slippery for the dog.
Oh yes.
Yeah. But I really want to get them home, and most of my clients are effective at limiting that activity.
そう、アニコムさんで何日ぐらい骨折だとアベレージで入院させてますか？
そこのデータはないんですけれども、ただ私が前に勤めてた時は大体3、4日から1週間だったかなっていうのをちょっと思い出したんです。
Yeah, around 1 week. Yeah.
1 week in the hospital.
Yeah.
Ah, that's a long time. Yeah, yeah.
But charge not so much.
Okay, yeah. You're probably losing money for that little bit after the surgery. For me, regular sized dog, like a 60, 70, 80 pound dog, cruciate repair costs anywhere from a low end of $1,700 for the small breed up to about $26 for the large breeds.
2600.
$2,600. The tibial osteotomy techniques that are available now, they typically $4,000 to $5,000
4,500
for the complete.
50万ぐらい膝でだから手術のコストすごいね
整形外科だとかなり多い方ですね、私も室外骨の
何が多い方？
整形外科の手術だとやっぱり室外骨が
室外骨多いね、 we're popular the patella things.
Okay.
Patella problem, yeah, because the small size
Yeah.
and lightweight, basically, easy to use.
Yeah. Yeah.
And we use we say paragard. Do you use sometimes paragard, like a triangle style metals that put it stick in the temperature sides, or we say paragard. Yeah.
For patella relaxation?
Yeah, but the relaxation, because it's usually 90% relocated to the inside, right?
Right.
So we make like a protect to the a very small triangle style metal metal plate
To
to stick in the bone, to the tibial bone. 結構tibial でしょ?
for your tibial crest transposition?
Oh yes. Like usually we more make deeper to use the drill. That work deeper
Right,
and
power,
sharp
right.
and put in the paragard. We say paragard, metal paragard.
I don't know that.
Oh yeah.
Yeah.
Oh yes. Like like this.
And
Then it's cannot don't that go to any sliding.
That metal stays in there?
Yeah, kind of. Yes.
You leave that in after the
Oh yes, yes. For like anti-diet, no problem. Yeah.
I'm not sure I understand what that is. I mean, when I do the
Yes, tomorrow,
chocolate
actually.
I use a mirror drill.
Yeah, in order to make smooth and more deeper and,
Deeper and smooth,
like,
yeah,
yeah.
yeah.
But inside it's something not enough case, so we put it in the paragard metal.
Okay.
It's a plate, but it's a design is a triangles, easy to stick to in, kind of stick to in because it's very sharp.
And that stays in the groove.
Yes. Yeah. 使ったことある？使ったことない。Oh, maybe tomorrow I have one go doctor he likes very much.
Okay.
Maybe
Let me-
like 100 times.
Yeah, okay.
Yeah,
I'm interested to find out what it is, yeah.
It's very working for small dogs.
Okay, okay. Okay, so there's a hole monitor tractor. This is the crimps that I use with the Securo system. So I have 6 crimps in each pack. Because I typically on the big dog I'm using 2 lines of 80-pound test nylon. This is the instrument that I use to spread those crimps apart to tighten it. And then this is the instrument, the crimper. You can see it's like a pin cutter, but at the end of it, it's been dished out a little bit, so it just puts a crimp in those little metal pieces versus cutting them. So, the attachment point for the extracapsular repair, you want to try and make it as close as possible or as isometric as possible. The suture going around the lateral fibula is a good option. I put a hole through the tibial crest. The hole that I make, I want to make sure that's as high as possible as I can get it into the tibia and as close to where the tibia starts to flare out to most closely mimic the normal attachment point of the cruciate ligaments. Fracture repairs, let's just go to some some specific radius and ulnar fracture. Here, this is your little dogs, your toy poodles, your Yorkies, Chihuahuas. Whenever I see a Chihuahua puppy or a toy poodle puppy, my first visit with the client, I tell them, this dog stays on the ground. Do not pick this dog up. Don't let your kids carry this dog around, because most of the times they break their leg because they either jump off the couch or they fall out of the kids' arms. Their bones are just so small. And I see here, this is an example of, this is Miss M. Bell. She is, oops, sorry. This is her AP view. So she's got distal radius and ulnar fracture. This one's very close to the joint. This dog weighed 3 pounds. So 1.5 kilograms or so. So I know what you're saying with these small dogs. They're all over the place. It's like working on toothpicks. This is the lateral view. You can see how close to the joint that is. To me, there's only one way to fix these, is with plate and screws. So that's the AP. I'm so sorry. Can we turn the lights off real fast?
Oh, here. Like this?
No, off.
Oh, okay. Sorry.
And I should have done better taking this light away. So this is the AP view of it. I'm sorry, it's upside down. Here's the elbow here. Here's the lateral view. So this is a 2.0 millimeter plate.
Titanium? Titanium?
No, stainless steel.
Stainless steel.
I was concerned I might have to use a T-plate on this one because I didn't know if I had enough room to get 2 screws below the fracture, but I did have enough room to get 2 screws below the fracture. When you're using plates and screws to fix fractures, you strive for a minimum of 6 cortical attachment points proximally and 6 cortical attachment points distally. Typically, 1 screw is going to give you both cortices, so that's a minimum of 3 screws. In some cases, you can get away with just 2.
How much weight of this case?
How much this one costs?
Weight. The
This
body
dog
weight.
was 1.5 pounds.
What? 100?
1.5
What?
pounds.
Under 100 pound. Oh.
No, one.
Only
1.5 pound.
Oh.
Not even a kilogram.
Oh.
Small, Yorkie.
Oh.
Yeah. So yeah, I know what you're talking about with these small dogs.
Yeah.
It's not, you don't pull any bone holding forceps out of these guys. It's all thumb forceps and hemostats. The nice thing about that is that they feel so good right afterwards that they're already running around 2 days after the surgery. Let's see, tibial crest avulsion. Do you see many of these? Like that.
やっぱり日本の多くの症例報告の写真と比べてやっぱり彼器用だね。非常に
So this dog, tibial crest.
肝心なとこだけいじってる。
You want to counteract the forces of tension on this particular bone. When I see these initially, what I'll do is, and sometimes you don't even need to sedate it, is I will take a series of x-rays. I'll take just a regular positioning lateral, and I'll take an extended lateral, and I'll take a flexed lateral. And what I'm looking for that is the distraction here is quite dramatic on this dog. So this dog definitely needed surgery without doing that. But if you have just a little bit of lifting of that, and you take those x-rays and you're not seeing that tibial crest is moving as you flex the leg, so it's relatively stable, these can heal very well with a splinted bandage. And they're typically young dogs, so maybe in a splint for 4 to 6 weeks at the most. But if you do need to take them to surgery, it's the tension band figure 8 wire.
テンションバンド使うよね。
So this one, anytime you have a distractive force on the bone, the tension band with the fixation wire converts those distractive forces to compressive forces. Bone heals much better under compression and it heals quicker under compression. So again, this is a satisfying surgery for a surgeon to do because they do so well so quickly after the repair is done. And this is just the AP view showing the figure 8.
破骨骨折ね。破骨骨折の。
That's an example of this. I don't think I need to go over the Salter fractures, the classification. Do I, Dr. Holma?
Sorry.
Do I need to go over the classification of different types of Salter fractures?
Yes.
Okay.
We have, yeah.
Okay.
Yeah.
So they look like noses, I know, but they're actually bones. So we typically have 5 types of Salter fractures. The physis will be represented by the red line there. So type 1 is the easiest, which was an example of, well, this one actually was a type 2 because part of metaphysis. But the type 1 is the easiest. The fracture just involves the physis itself. Type 2, which was this one, fracture involves the physis and a little bit of the metaphysis. Type 3 is physis and articular aspect. Type 4 is just a combination of all of those. So as you get higher in the classification system, the complexity of the fracture gets worse and the prognosis gets worse a bit too, because now you're dealing with articular fractures. And then the 5th type is, I represent this as a compression fracture. So the forces compress that fracture radiographically. You may not even be able to appreciate that because you'll still have the non-mineralized zone. This is the most damaging to the physis, is the compression fracture. And that brings up those dogs with the radius and ulna fracture in the young animal. So the radius is kind of like this, and then the ulna comes down. It should be down like this more. So that's what it looks like. The ulnar physis is a conical shape to it, and the radiophysis is straight across. When these animals suffer a fracture that's hard enough to damage or fracture the bone, oftentimes the physis is damaged at the same time. So when I see these people, initially at the initial examination, I tell them the prognosis for the repair of the fracture is good. We can usually get the fracture to heal. Prognosis for development of growth abnormalities at that point is guarded. Because I want to instill upon these people the idea that we got to watch this leg very carefully. As soon as we start to see it turn like that, it indicates that the ulnar physis has been damaged. Most of the times it's due to the ulna, and that's because of the conical nature of it versus straight across. Any force applied to this physis from any direction, there's going to be some compression of the physis because of its shape. Versus this one, really compression is only going to be noted with force generated that way. A lot of times your forces are coming from the side, and that's going to cause the shear at the non-mineralized zone, but that shear doesn't destroy the germinal cells of the physis. It's only when they have the crushing injury that will cause those germinal cells to be damaged. So that plays into when you're doing the surgery too, is whenever you have these Salter fractures, typically they're going to be young dogs, so the bones are softer, and be very careful with the types of reduction forceps you put on them, because you can crush the bone very easily. And also, when you're reducing them, you want to make sure you don't grind the pieces back into reduction. You want to try to distract it as much as you can to move it in place and then seat it in there. The more grinding you do to try to reduce that fracture, the more damage you're doing to those germinal cells, and hence consequently with the growth disturbance. So for these guys, I watch it very carefully. First instance, I see that they might be turning a bit. We confirm that with x-rays, and the first thing we do is we take them into surgery and do an ulnar ostectomy. So I take out a portion of the ulna, the mid shaft of the ulna. That relieves the restrictive influence of the ulna on the growth of the radius. And if you can get that done before they have an appreciable amount of curvature, they should be fine the rest of their life. Usually your definitive surgery, if you have a very crooked leg, is going to be done after the animal is done growing. Any questions on those? No.
In this case, like a humeral or like a femoral or humeral? Both?
Most of the times it's going to be the radius and ulna.
Here?
Yeah, I've done a lot of young dog fractures, femur, tibia, humerus. Doesn't seem to be quite as much of a problem.
Yeah.
I think it's mainly because of the
lateral line? Yeah?
Yeah.
Okay.
So those are.
そう成長期のね、成長期の 骨折における注意点のよく破骨を起こすところのパターンだよね、それについての注意事項と力のかかる方向性に対するアプローチの、方法、こう骨がバチンと割れちゃわないようなアプローチの仕方だよね。So, thank you very much.
Sure.
Maybe tomorrow our doctor is the question about these things.
Okay. Jaw fractures.
So, by the way, one more my
Yeah.
question, okay?
Yeah.
So, after this kind of like a fracture treatment, I use vitamin A-D3 injected. After that, it is working or not? Because even me, I don't know. Just I do it.
I don't know. My personal feeling is none of those things are going to work. As long as the animal is on a good diet, he's going to get everything, or she's going to get everything.
Because
she needs
the
for-
big size dogs, sometimes even no fracture, there's a problem about this kind of things. By getting the
the growth disturbance, or
no, it's like a pain, and also they are easy to break, not relocated, because a big size dog is very growing so fast, right?
so maybe you're dealing with
Like this, like a arm like this, or like this.
Maybe you're dealing with panosteitis in that dog.
Vitamin D3 problem?
Not for me. As then I see.
Because sometimes it's very strange for the pure dogs, like Akita,
Yeah, but maybe the problem is because
Great
of,
Dane.
maybe because of the supplementation. As I know a lot of, especially Great Dane clients, they come to me, oh yeah, my breeder told me I gotta supplement calcium. I said, no, you don't supplement calcium because that's the worst thing you can do.
Yeah,
The-
exactly.
The foods are made to have an appropriate ratio of calcium and phosphorus. So as long as they're feeding appropriately, the animal's body should take care of that. So I don't typically use supplements to impact bone growing or fracture healing. Yeah.
How do you think it X of the legs are X design, like the big size dog also very high.
So the dogs are like this,
Yeah.
mostly hip dysplasia.
Hip dysplasia, but
And
from
patella-
hip.
and
It's
patella
from hip.
position.
Or patella.
And then we always have those dogs that have very poor conformation. Unfortunately, I see quite a few in the Akitas because they tend to be very straight-legged.
Yes,
Yeah.
like movement.
They don't have the nice
Yes.
shape. They're very straight-legged, so they don't have good resilience in the joints. So I see a lot of
It's
those.
basically framing problem, right?
It's what?
The bone framing problem.
Yeah, it's just their conformation.
Yeah,
doesn't
because it's
support-
from the design, from the gene, generally.
Right.
Yeah.
And we've done it to them because we've bred these dogs to be like this.
Okay.
Jaw fractures, I put that up there because I hate jaw fractures. There's too many teeth in there. I gotta be careful where I put my fixation devices. So usually with jaw fractures, I try as most as I can to do intraoral techniques, not having to go through the mandible. So interdental wiring, interarcade wiring, even tape muzzle, things like that. I try to not do an open approach to stabilization because of the risk of infection and the placement of the teeth, especially if it's a puppy and you take those x-rays, you can't even, I mean, there's teeth all over the place. It's hard to find an area where you can safely place a pin, for example, or a screw, for example, without damaging teeth. So for the jaw fractures, as much as I can, I try to use intraoral techniques.
Yeah. Because many cases in the middle of the
Oh, the cats,
is
yeah.
like this.
Right, yeah. And that
Usually
was-
wiring, right?
Yeah, that's a real easy one,
The
yeah.
canine teeth to between to this, like.
Yeah, so you introduce an 18 gauge needle from the bottom, and go work it up the side, come out right behind the tooth,
To
put
the
your
wall.
wire in.
Like
pull
this,
out,
like this.
And then go the other
Like
way,
this.
and then loop around like that.
This.
And then twist, yeah.
Like this, yeah?
Oh, no, like
No,
this.
like this, to the center.
Yeah, to the
Like
center.
this.
Yeah.
Like this, okay. Yeah.
Those are the good ones to have, because they're not easy. References. This, I think, if you're going to, I'm sorry it's upside down again. If you're going to do orthopedics or fracture repair, you need this book in your hospital. Very good diagrams as far as how you approach these joints and bones.
Approach to the bone, yeah.
This is Handbook of Small Animal Orthopedics and Fracture Repair. another one that's very, very good. This is actually the new edition, just came out. So this is the new edition. This goes through everything as far as the joints. The only thing it doesn't cover is spinal surgery, as far as like disc herniation and things like that. But it does have some fracture repair techniques for the spine. This actually is a picture here of the femoral nail right there. You can see the two, and that's actually being used in a tibia. And then my other favorite book is this book out of England. It's specifically for feline orthopedics. There are enough anatomical differences between the cats and the dogs that it would be a good idea to have this available. Cats traditionally are good to work on with orthopedics because you can, as long as their bones are in the same room together, they technically will heal. Now this one shows a total hip replacement. I don't know if I do that on the cat, but that's what they have on the cover. Okay, so these are some fractures here. This is the tibial crest avulsion, which we've already seen. Can we do the lights again, Katsumi-san?
Oh, okay, sorry. Yeah.
Okay, so let's repair that. Here is our radius and ulnar repair on our little 2-pound dog. Okay, this is this dog, a Rottweiler puppy. You can tell he's a puppy because he still has open growth plates. Femoral fracture. Nice thing about this, it's a long oblique fracture. So this
pin?
Pin. Yep, pin and wire. And that's the AP view. And there's your pin.
Oh, this is the new one.
Yeah. So this one, if I were to be criticizing my own surgeries, I would have liked to have gotten this pin a little bit further down the bone. And I would have liked to have used maybe a bigger pin. That one's a little bit on the small side. But I was okay with that because this dog is so young, he's going to heal very quickly. So that was his...
This is a nail pin, right?
What's
It's
that?
a nail pin. Nail pin.
No, this is just a regular IM pin. This is not the nail.
What do you use for the nail? Oh, no, wire. Sorry.
Cerclage
Yeah,
wires
yeah.
to hold
Sorry.
the fracture. So when you're going to be using pin and wires to repair fractures, a general rule of thumb is that they should be oblique fractures, and the obliquity of the fracture, the length of that fracture should be twice the diameter of the bone. So if it's a shorter diameter, it's got to be twice the diameter of the bone, so you can get at least 2 wires, right? If it's a short oblique, you can't get 2 wires there. If you try to do 1 wire, that's just going to act as a fulcrum and cause your fracture to distract. So a general rule of thumb, obliquity needs to be twice the length of the Kyoko lights.
Sorry.
That's okay. And that's the AP view. On the AP view, it always makes it look like the pin is too short, but that's because the angle of the leg against the plate, the radiographic surface. Okay, this one was not fun.
Oh my God.
This was hit by car. You can tell there's problems on that view. You can't tell exactly the extent of the problems. Here's the AP, or the VD view. So we have a ilial body fracture, we have ischial fracture, we have a pubic fracture. Back to the lateral view, we got an avulsion of the tibial tuberosity where the gluteal muscles attach. On this film, there's another problem that when you have pelvic fractures, you always want to make sure about. I don't see a bladder. So he also had a ruptured bladder. Yeah. So that dog, the day he came in, we had to take him to surgery to repair.
It's also female.
Yeah. No, that's a male.
Oh, male?
Yeah.
Oh, that's lucky.
Yeah. So this boy, we had to take him to surgery that night or that day to repair his ruptured bladder. And he stayed in the hospital the next day. The day after that, we took him to surgery. For for pelvic fractures, treatment of choice is going to be plates and screws. Yeah, the bone lends itself very well to plates and screws. If I were to criticize this technique or this fracture surgery, I would have liked to have put more contour in that plate. I don't think I put enough contour. If I put more contour in the plate, that would have brought the pelvis out a little bit further to improve the pelvic canal. But you notice I didn't fix this, I didn't fix these, I didn't fix the ischial fracture. Once you get the ilial body fracture together, those all tend to line up pretty well, and they're not weight-bearing parts of the pelvis, and so they heal by second intention bone healing. Unfortunately, and we knew that before the surgery, this dog also had severe neurological damage done. So he's able to walk. He's a little bit ataxic. He wobbles around a little bit, but he is able to walk at least. And so they're happy for that.
And did you fix that bladder?
Yep, bladder was fixed the very first day.
Mm-hmm.
Yeah, this surgery occurred 2 days later.
Mm-hmm. To open, right? So
The bladder?
Yeah.
Yeah. And that's the side view. When you're doing these, and this one wasn't able to do it because of the location of fracture, but if you can introduce one of these screws into the sacrum safely without penetrating the spinal canal, then that will improve the holding power of your plates and screws, because when you get to the cranial aspect of this bone, it's very thin, it's very soft, has a hard time holding onto screws because they'll strip out very easily. So to get at least one screw into the sacrum will help with your stability. And I think this is the last one we have. This is a cat, and you can see it's a young cat, thank goodness, but you can see the comminuted nature of his femoral fracture. He's got 2 main fragments, lots of small fragments. Going into the surgery, my plan A, and you always want to have a plan A and plan B going into these surgeries because you're not never sure what you're going to be confronted with when you get in there. Here's his AP view. So but my plan was on this one, especially since he was a cat, they have nice straight femurs. He's a young cat, he'll heal very quickly. My plan A was to rebuild the entire cylinder of the bone, stabilize that with cerclage wires, and then place an IM pin. When I got in there, a lot of these fragments, whereas they look like pretty big, they're very small, was not able to rebuild the entire cylinder of the bone, so had to go to plan B, which was a plate and pin combination. So I have screw fixation proximally and distally. This is pretty much just an open gap here, and then I have a pin to help provide axial stability to this one, and this is the lateral view. Okay, so you can see though that I didn't really get this proximal fragment as close as I wanted to the distal fragment. But he'll go ahead and fill in bone there. As long as his hardware stays in place, he should fill in that bone and do fine. This cat, 2 weeks later at the time of suture removal, I wanted to see how he was walking. Clients have been keeping him in a crate into a small confined area. So I put him on the ground, and he's kind of a scaredy cat, so he just took off running, using all 4 legs very well. So cats are very rewarding surgeries to do on cats because they heal very nicely, and their bones are straight, and they tolerate these things very well. Arigato. I'm sorry it took so long. You guys worked today, and you want to get home.
Good job. Thank you very much.
So thank you
Very much.
for having me.
そう、最後に質問よろしければ最後に受けてどうでしょうか、全体的に。
You said the number of VCA hospital in Hawaii is growing in these 5 years, 1 to 6.
Yep.
So how much money are those veterinarians are able to receive from the VCA office?
So the compensation for the veterinarians?
Yeah.
So Depends on your level of experience and how long you've been in practice. For the new graduates, fresh out of school, they start them off typically about $55,000 a year as a base salary, and then they get a certain percentage of their production every month. They typically will start those kids off at about 17-18% commission on production.
Yeah, from the product also.
How about experienced?
Experienced doctors, depending on the level of experience, they may start you off at anywhere from 70, 80, maybe even up to $100,000 as a base pay, and then your commission is also higher. For myself, I get 22% commission on my production.
The production things are like a 10% all into the for income, for the sales, because VCA has lots of medical service income.
So we don't.
Sorry.
No, go ahead. Go ahead.
So because they are on the market, public, wolf market. So this is like a public company, right? And there's so many the private clinics they buy. Yeah, kind of M&A style, right? Yeah. But
So-
he's totally originally for the working for a long time.
One thing I will say to VCA's credit is that their compensation for the doctors is good. I think even the new graduates, it's pretty good.
VCA now is the most individually most biggest veterinary hospital in the world, more than bigger than the Banfield, because Banfield is totally like a yeah, like a kind of like a one-way style for the under the road canal, right?
We call it cookie cutter.
Cookie cutters.
Their doctors actually see the client, they develop a list of clinical signs that they're seeing, and they punch that into a computer, and the computer tells them what the problem is. And they also are, as far as I'm aware, they are corporates always looking at what they're doing. You're not doing enough urinalyses this month. You need to do more urinalyses this month. You don't do enough injections on your appointments, so you need to do more injections. So that's a kind of feeling you get from the Banfield type of organization. VCA, much better. They do allow the individual practice of medicine. But at the same time that they do that, they send you a lot of information about the quality care. So they're very, very much involved with that.
And even Hawaii is now in these 5 years, all the consumer pet owner so much more looking for the VCA, because the VCA started in 1996, right, in Hawaii.
Yeah, that's when we bought the practice.
So in this only 5 years, there are 5 more now, because it's a kind of a like a pet owner movement looking for the more service, good service, 7 days open, the early morning to the night. Yeah. It's a kind of a
Even
service.
newly graduate can receive 100,000 plus percentage.
Well, if
Depends.
I think it would be unusual for them to be able to produce that much to raise their salary that much. But most of the times, within a month or two after they've started with us, they're already making their base and they're into commission. So if you don't make your base, then you don't get commission that month. Bad thing is that if you don't make your base, they know how much you missed it by, and you got to make that up the next month. So it's a little bit punitive in that sense, because they'll keep tabs on how much you're under. I don't like their vacation policy either, because you're based upon production. Of course, you take vacation, which they say is a paid vacation, but you're not there to make production. So if you don't make production that month, you suffer for it the next month. So it's not actually a paid vacation. We're pretty much paying for our own vacation. And I don't agree with that.
No M&A case, for instance, VCA office pay million and veterinarian will be moved to VCA.
Yeah, together. Yeah, it's a real M&A case, right?
What?
Because example like Dr. Naito's and other clinics they buying, right?
Oh, yeah.
Yeah, this case then expanded, right?
Yeah.
Yeah.
So what the VCA will usually ask the owner of the practice that they're buying, they want that owner to stay as an employee for at least a year, maybe 2 years, just to continue to maintain the goodwill of the practice. But VCA is always looking for practices to buy. They're always looking.
Especially this 5 years, very aggressive. But sometimes I think they pay too much to the business, not the employee. Employees actually, I hope more pay. Yeah. But by the business, I think sometimes overpriced. I think.
The practices they purchase.
Yes. Yeah. Because they're looking for another 10% every year growing. Right? It's a kind of a stress to the doctor.
Yeah.
That is my reason.
Yeah.
So if the more stabilized to the amount, maybe more better practice in the long term.
Not so much pressure.
Yeah. Because in this recent years, I had some of the client is a VCA, it's a good service, but the price little bit higher than other clinics.
Yeah.
In Japan, my clinics not expensive, but maybe little bit lower than the private clinic. Because we buy a more cheaper cost of the medicine, right?
Bigger.
Yeah, then I want more like a service to the client.
Right.
Yes, yes, it's something like my business thinking all the time.
Yeah. The owners of VCA, or the two fellows that started VCA, came from the human field, in fact, human insurance field. So they love their own animals, so they wanted to get into the veterinary market, and so that's where they started VCA.
Thank you very much.
Thank you.
Thank you so much.
Thank you.
This is a totally deep discussion, including medical techniques and also management techniques.
Thank you, Masa. Thank you.
ありがとうございました。すいません。ありがとうございました。わざわざ今度金曜日にね。今日のまたあれはDVDできたら。